Everyone, welcome and thank you for joining in our Stovit online series hosted by Faculty of Dental Medicine, Universitas Erlangga, Surabaya. In today's webinar, we will have three sessions. The first session is a lecture about building comprehensive dental management system that will be delivered by Dr. Azlan Jafar, BDS, MDPH, Doctor of Public Health from University Sains Islam Malaya. He will also give a lecture in the second session of today's webinar. It's about dental clinic cost management system. In the third session, we will have a lecture about management of HIV/AIDS, back to basics, delivered by Dr. Erwin Astatriono, SPPD KPTI Finasim from Faculty of Medicine, Universitas Erlangga, Surabaya. Now I'd like to introduce myself. My name is Dini Setiawati. I'm a lecturer in Dental Public Health Department, Faculty of Dental Medicine, Universitas Erlangga, and I will be the moderator for the first and the second session of our today's webinar. In the third session, I will pass the moderator task to Dr. Diki Regina. Before we start our first session, I would like to welcome our remarkable speaker, Dr. Azlan Jafar. Assalamualaikum. Good morning, Dr. Azlan.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you for taking time for your busy schedule for giving a lecture in our today's webinar. We really appreciate it. And nice to see you again, Dr. Azlan.
Yes, me too.
I also would like to welcome our Vice Dean of Faculty of Dental Medicine, Universitas Erlangga, Dr. Andra Rizkiawan.
Halo, Assalamualaikum warahmatullahi wabarakatuh.
Hello, Dr. Andra. Would you like to say something to Dr. Azlan?
Dr. Aslan, thank you very much for this opportunity. So I hope I can see you in Surabaya, and maybe I can visit you Malaysia.
Yeah, welcome. Yeah, welcome.
Yes, thank you very much. Please.
Okay, thank you, Dr. Andra. Okay, before we start our first session, let me briefly read Dr. Azlan's curriculum vitae. Dr. Azlan Jafar is a senior dental lecturer in periodontology and community oral health, University Sains Islam Malaysia in USIM. In 2006, he graduated from University of Malaya, Malaysia as a Bachelor of Dental Surgery. Then he got his Master of Dental Public Health from University Sains Malaysia in 2012 and completed his Doctor of Dental Public Health in 2015 in the same university. Dr. Azlan has an expertise in dental public health with interest in epidemiology and statistics, research methodology, oral health literacy, geriatric dentistry, and dental entrepreneurship that is suitable to his webinar topic today. He has a great number of scientific publications, including journal articles, book chapters, and newsletters. He also has been granted a number of research funding and also innovations awards. Now, let's start the first session of our webinar today. Dr. Azlan will give a lecture for about 60 minutes. At the end of his lecture, we allocate 15 minutes for discussion. So all participants are welcome to send questions to Dr. Azlan through our Zoom chat room. Well, Dr. Azlan, I invite you to start your lecture about building comprehensive dental management system, and you may start your lecture now. Thank you.
So maybe I need help to get my slides on. This is my first time using Zoom, so maybe Gia.
Yeah,
I need help to share my slides. Yeah.
Okay.
Oh, okay. So should I? So I myself can share, right?
Yeah.
Yes.
Okay. I try first. Okay.
Just use the share screen button and you can share your screen.
Can you see? Can you see the slide?
Okay. Yes, that's right.
Okay, thank you very much. Okay. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin wassalatu wassalamu ala asyrafil anbiya wal mursalin sayyidina Muhammad wa ala alihi washabbihi ajmain. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Rabbi zidni ilma warzuqna fahma. Okay, today, first I want to thank the University of Selangor for inviting me to giving the lecture. Okay, so I'm Dr. Azlan. Okay, graduated in Malaya and have been introduced by Dr. Dini. So today we are going to talk about how you're going to build to build a comprehensive dental care management system. As I can see, most of you are still doing your undergraduate. Okay, and maybe several years you are going to open your own clinics. Okay, or working with the government. But today, most of my lecture is talking about how you're going to, or the methods that you should choose or use to open your own clinics in the future. Okay, as we all know, as a dental students, okay, we have been occupied with a lot of knowledge and also informations on how to become a good dentist, right? Okay, we have been taught about the medical and dental knowledge, okay, when you are in the pre-clinical year, okay, you've been taught about the anatomy, what are the things in your body, okay. We talk about physiology, and when you're in clinical year, we talk about the how to do the fillings, the restorations, how to do some extractions. So all these have been occupied in you, okay. And also you have been taught about the interpersonal skills, okay, like communication skills, okay, hard skills, soft skills, okay, ethics and professionalism, how to become a good dentist with an ethics, okay, how you're going to deal with your patients and how to become a professionalism, okay. How to do an optimal clinical competency. Maybe you have been tested with, for example, you have learned about how to do restoration. So from there, there is some competency test that you have to achieve, okay. You also have been taught about how you're going to manage your patients, okay. For example, patient with complaints, okay, patients who have problem with communication with you, okay. And also you have been taught in dental public health about how to do health promotions and health education to patients. For example, if patients having a bad oral hygiene, so how you're going to promote or how you're going to educate in the chair sites or going to the fields to do some health promotion. All this knowledge that you have been teaching, okay, have been taught during your how to call it, during your preclinical or the clinical years, is really superb. I mean, it's like you have been prepared to become a dentist, okay. But the problem is that there is a lack of business skills most of the time. I think in our university also we have been lack of business skill being teach in dental students, and also how to manage our clinics in the future. For example, if you work with the government, okay, what is the things that you need to know when you're going to manage your clinics? Or maybe if you open your own clinics, what is the best way for you to manage your clinics? Or managing and also leading the clinics also is different. So this kind of thing does not been teach to the students. Not, I mean, not been teach, meaning that you are not been part of it, but most of the university have been there, okay, like teaching them, studying there, okay. We don't have this kind of skills, okay. So how about when you are leaving the schools, okay, you have done all the you have get your scrolls, your degree in the dentistry. So how are you going to do this, okay, the business skills and management skills? There are a lot of studies I've been read that saying that the needs of doing this practical management system, okay. I've quoted some of these studies, okay, like here from Nazir et al. This is from Pakistan. Okay, they say that there is a need to learn practice management system among the undergraduates, okay. Barber also saying that we need more time to learn practice management principles during undergraduates to prepare ourselves in real life. So again, there is a need of the practice management system, the way on developing or managing the clinics, so that you are not doing harm to the organizations, okay. And lastly, besides clinical skills, the non-clinical skills such as business and communication skills should be included during undergraduates, meaning that even though you are very good in your clinical skills, but they're still saying that the needs of learn about the business skills, okay, the business management skills, and also communications, the part of you with your patients. Sometimes when you talk with your patients saying that you are not really understand about them, okay. Now people always talk about patient centered, right? So I have okay. Just want to sharing some of my experience. Okay, um, this one is I'm like talking with my one when we have a discussion with my friends. The differences between Malaysian patients and also in part of the Europe countries. Okay, usually you are a specialist, you have been doing some locums or OT. Okay, in the some of clinics. Okay, so sometimes in these clinics there is a patient from outsiders like from England, from UK, from America come to Malaysia to have a dental treatment. My friend said that he tried to approach patients by saying that they need to do this kind of treatment, and then you know what the patient said? Patient said, "You don't need to tell me what I need to do, what I need to have or what I need to do." See, sometimes we think that our conversation with patients, sometimes we feel that it is okay. We feel like this is a way on telling patients about what they need to have, okay, what they need to do in their mouths. But because of their culture, the origin of the patients, sometimes they feel that, for example, in Europe, okay, they are more on patient centered. They are the one who should tell the doctors what to do, not us to tell them what they should have. So this kind of communication also is very important for you to learn on how to approach patient, the correct way on approach patient when you do treatment, when you want to when you want to treat that patients and have them again in your clinics. So it's very important. That's why some saying that it's important for them to learn, okay, on communication skills. Okay, for today, sorry, if you think that I am quite fast, you can stop me. I will try to make it my pace to be a little bit to that you can follow. Okay, so for the content, okay, today my content will be a big of a small one, talking about what is the health atau dental management system. Okay, today the three component content is on my lecture is talking about the definitions, okay, definition of dental practice management system. Second is the component of that, what are the components inside the dental management system, and lastly talking about business strategic planning. Okay, and when you all know all the content inside the practice management system, what are the things that you need to know when you do want to open your own business, dental business. Okay, before that, last week we just have a lecture with my professor, okay, talking about managing dental clinics. Okay, you have to remember, okay, although that you think that now people now because of the globalizations, because of the needs of dental treatments, okay, those days during my time after we graduated from dentistry, we have to work with the government. It's compulsory work with government, and majority of us will work with the government. But now the world is changing. Okay, like in Malaysia, we are compulsory to work with the government for three years. Okay, under contract. But later, you have to be out to work, either joining the private sectors or open your own clinics. Okay, but again, we know that healthcare is not what do you call it. He said that dental health is not a business. Okay, it is a needs of the populations. Okay, but again, as he mentioned that we cannot run from putting business into the dental health. Because why? Because of all the policies, the changing of policies, etc., etc. So because of that, you have to again put in your mind that all people need to have the dental health. But again, because of the policies, because of the changing of the world, business should be part of it. Okay, because you cannot sustain your clinics unless you have the business inside your into your clinics. Okay, again, you have to remember that. Okay, so don't put business ahead. Okay, in front, but business is part of the dental health. Okay, now look into definitions. What does it mean of dental clinic management system, okay, or practice management system? It's a set of mechanism, okay, resources and processes in terms of planning and budgeting, organizing and staffing, controlling and problem solving related to dental clinics to meet the needs of patients. Okay, so there are several components related to the dental clinic management system. So there are also other meanings of dental practice management system, because if I put on the title, some of it I took clinical management system, and other part is practice management system. So what are differences between these two? Okay, it actually does not have any differences. Okay, maybe it's a overlapping meaning. So you can use clinical management system, or you can use dental practice management system. It's about the organizations and operations of the business aspect of dental practice, including but not limited to supervision and control of patient flow, staff assignment and evaluations, record keeping, and financial overseeing. So both have the same meaning. Talking about human resource, okay, the resources, the planning, the budgeting, staffing, how to control it, and also the financial financing the clinics. Okay, so talking about this management system, okay, developing it into a very good one. So you have to have a control on all these components. Okay, so because if you, I think when you do your clinical works in your clinics, okay, you think it's a lot of things I have to worry about. I have to worry about my patients. I need to worry about my requirements, how I'm going to put my appointments patients, how I'm going to manage my schedule of patients, how I'm going to adhere with my supervisors. All this being a lot of things when you do your clinics, okay. But okay, I'm trying to put all together on simple way on how you're going to manage your clinics, okay, or in the future, or you are going to open your clinics. How are you going to manage all these things into one thinking? Okay, the concept of doing the management. Okay, there are three principles I put in three P's. Okay, first is the people. Who are the people that you are managing? Okay, what are the policies involved in the clinics? And lastly, how are you going to practice? Okay, how are you going to practice these things so that you are going to manage your clinics appropriately? So people, okay, we are going to talk about what are the people involved. Okay, policies. Okay, what are the policies that you need to know that can not interrupting. Okay, but the things that you can control so that you can manage your clinics freely. Okay, and lastly, how are you going to practice your clinics? Okay, based on certain things. Okay, now you're talking about people. There are two kind of people involved in your management. Okay, first is your client or your patient. Okay, usually I don't like to use patient, because when you talk about patients, you always say that you are the primary person that should tell your patients. No, not anymore. If you look most of the literature, they don't call patients as patients anymore. They call them as a client or customers. Okay, or if you talk about patient, they're going to call as a patient-centered, means that patients are the one who need to make the decisions. Okay, there are two kind of patients or clients here. First, we call as a new patient, and second is the loyal or repeated patients. Okay, when you have a patient, usually, for example, if you treat patients when you are first time enter your clinics, okay, you might given a new patient, okay, the first patient that you see, okay, but after a while, okay, after you have opened the patient folder, that patients, when they repeat, then they come again in the appointment, we call it as a repeated patients, or I always use a loyal patients, okay, because they are loyal to your clinics, okay. So you are going to manage this patient, this kind of people, okay, and the other person that related or have the bond with the patient is their families, their friends, okay, their neighbors. Okay, why I said that, because sometimes these people also can influence your customers. Okay, for example, okay, you open, okay, for example, Gia opened her clinics in part of the Surabaya. Okay, she have a very good clinics. Okay, suddenly, okay, there is a new patients come to the clinics. Okay, and Gia treat patient, the way she communicates with the patients really good. Okay, the patient love Gia very much. Okay, and what do you think that patient will do next? The patient will tell about the clinics to other patients. We call it as mouth-to-mouth reference. Okay, she tell to the people in the area. Okay, oh, this clinic is very good. Okay, this clinic is very pleasant. It's very convenient. Very good. Okay, the setting is very good. You have to go to see Dr. Gia. Dr. Gia is very beautiful. She's very nice. So this is very. That's why I said these people actually can help you to improve your own clinics. That's why every time when you see patient, you have to always think that what should I do that can help the patients to help me again? Not saying that, okay, how are you going to give the optimum treatment to the patients so the patient can have a better understanding about your intention to help them. So from there, they will influence others to come to your clinics and you can have a good clinics later. Okay. Or the other way around, if you are not that nice, how you talk with patients is not that good. What do you think about that later? So patients will not come, and you are getting a less number of patients to come to your clinics. Okay, so the first one. Second is the human resource. Okay, in human resource, okay, what the means of human resource, the people who work with you. For example, okay, I will talk about later about the example of the human resource, but the two major human resource inside your clinic is the administrative and also the clinical. Okay, so we'll look into it later, what is administrative and what is clinical. Sorry. So let us see a bit about the clients. Okay, there are several things that you need to know about the patients, the clients. Okay, first is the primary source of income. So you have to understand that your clinics, okay, the patients is your income. Okay, if you open a clinic, okay, or even if you're working with government, so the patients is actually your income, the primary source of income. Okay, so what you need to do again, you have to give them a first class services, and you have to polish your communication skills. Okay, and there are several services that involve with the patients or the clients. First is the counter. Okay, I have experience handling the one of the clinics under USIMS. We call it as a private wing. Okay, and also my wife is she's opened her own clinics. Okay, so I'm not part of the clinics, but usually I become the consultant, telling her what to do, okay, on the management skills, because I'm the public health, so we learn a lot about management, etc. And also I'm involving in the entrepreneurships. Okay, she always consult me about how to do certain things when they have problems. Okay, this kind of counter, and one of the problem that she faced early of her clinics. Okay, she have this kind of patients who always argue when they have problems. Okay, when we try to evaluate certain procedures that we did. Okay, the problem that happened is in the counter. Okay, uh, some of the examples in the counter is that, okay, when patients came to clinic. Okay, if you go in for example in the to the shopping complex, you go to some of the shops. Okay, you can see the workers always play with the handphone, right? I think students also did the same thing. Okay, I also did the same thing. Sometimes we are very into the phones. Okay, you talk with the patient, the friends are using phones. And patients come, the first impressions when patients come into the clinics, looking at the counter, the workers is looking at the phones, they are very annoying. Okay, that's why when I always talk with my wife, say that you have to make sure that the counter services is super. Okay, first class. Okay, you have make sure that patient when they see the patients coming into the clinics, please put handphone aside, focus to the patients. Okay, to the clients, greet with smile and talks softly. Okay, one of the example. Okay, patients come. Okay, can I see doctors today? I say, can I know, have you made any appointment today? That's how you should say to the client. Because the first thing, for example, the patient come, I have appointment today. Is it okay? When have you booked? So when this kind of conversation happen in the counter, what do you think? I think if you are the clients also, you feel annoying, right? You feel that it shouldn't be happen to me, right? So this kind of thing shouldn't be. You shouldn't control these kind of things even in the counter. Okay. Second is the clinical. Clinical is, I think you know better. Okay, you know what are the material, everything, and in the surgery room. And lastly, is financial. Financial is very, very important for you to sustain your clinics. We'll talk it later. And lastly, is a patient-centered. Okay, I always put it in my slides because I feel that patient-centered, educate patients is very, very, very important. If you think that patients know better, no. Even though they know better, you should educate them. Okay, how to educate them? There are a lot of ways in you for to educate patients. You can use the websites. Okay, by appointment based. Okay, how to handle the complaint with patient have a complaint, also in the chair side. Okay. Um, in the website, I think when you have a clinics, okay, the best way for you to market your clinic is by having a website. Either you use Facebook, use your Instagram, use your own websites page. Okay, appointment meaning that sometimes. Okay. Again, I will talk you my experience. Okay, appointment. Okay, one of the problem with appointment is that when patients call to come to your clinics, okay, they set appointment. Okay, for example, like today at 5 o'clock, around 3 o'clock, you are going to have an appointment with patients, and then you wait for the patients. Three patients does not turn up. 3:15 still no. Then you call. Hello, patients, are you coming? Oh, sorry, I'm on my way to your clinics. Okay, but for 3:30 you have another patient. So how are you going to handle this kind of patients? So you need to know how it's going to be, and what are the best way to what do you call it, to make sure that this kind of things is not happen. Is happen, how are you going to solve the problems? Okay, so all these things very, very, very important. I think if you want to know better about these things, maybe you can read later. Okay, if you want to have a reference, you can ask me, and we'll tell you later. Okay, so that's all about the patients. Now we're going to the human resources. Okay, there are a lot of things or quite related to human resource. Okay, I put it, I take it from the internet. Okay, but it's very, very important. Okay, human resource is about how you're going to recruit your personnel in your clinics. Okay, I have an experience interviewing some of the dentists who want to work with me with our clinics in private wing in USIMS. Okay, one of my, okay, I just give a tips. Okay, I read a lot of literature on what are the things that if you, for example, if you have a clinics, what are tips that you can use to identify whether these doctors or your assistants, etc., is the patient, the person that you need to hire. Okay, one of the thing I always remember, my boss always said that wait 5 years for you to see what will happen to you later. Okay, I try to imagine what does she means of 5 years. What does mean of this 5 years? Okay, I always think it until I found the reason of 5 years. Okay, if you look into the government, policies, they always talk about 5 years, 5 years, 5 years. Like in Malaysia, we have the RMK, we call it as a Rancangan Malaysia Ke, etc. If you see this Rancangan Malaysia of the government, they always put at 5 years ahead, 5 years and 5 years and 5 years. Because if this person can see what will be another 5 years, mean that this patient have planned. This person have planned ahead 5 years later. So you can see that, for example, if you hire her, okay, what you think of you after 5 years? You said, oh, I'm going to be this, I'm going to be that. I don't know, I don't have any plan about 5 years. So it means that these fellas have nothing in her mind that could transform her to become what you want. Okay, this is one of my tips. Okay, it might be wrong, it might be right. Okay, but if you are the person who are always planning, so 5 years planning is very important. Okay, so if you the things is that when you ask the person that you want to hire, you have to know what is actually the plan. If you say that, oh, after 5 years I'm going to open my own clinic, so the things that you need to think is that, okay, oh, after 5 years she want to clinic, so why not I'm doing a franchising. I'm taking her to be part of my shareholder to open a new clinics in certain areas, right? It can be one of your plannings later. So always have when you hire something, you must know what their intentions. Okay, are they going to do something that that can help you later in the future? Okay, and how to manage them, skill trainings. Okay, if you have problem, if you think that your person at the dentist need to have a skill, so you need to help them with the skill training, etc. Okay, now we're talking about the type of personnel. There are several type of personnel I have mentioned earlier. Oral personnel, also the administrative. So who are the person that you need to have in your clinics? Okay, first is the dentist. Okay, dentist, definitely. Or maybe you, the first time you open your own clinics, so you are the dentist, and you are the manager. Okay, next is dental hygienist. Okay, I don't know whether in Indonesia do we have a dental hygienist, but in Malaysia we don't have a dental hygienist. Okay, we have dental therapists, dental laboratory technicians, and also dental surgery assistants. Cool. Okay, so all of these personnel should be in your clinics. So if you don't have, you must have one. Okay, but for dental lab technicians, okay, like in Malaysia, we don't have dental lab technicians in private wing. Usually, what we did is that we outsource it. For example, you have denture, we don't have in-house dental lab technician, so we outsource it. We send it to the lab to do it, and then we paid for the work. Okay. Administrative, okay, based on my experience, manager is very, very important. If you are not, for the first 5 years, okay, okay, I'm talking about 5 years again. First 5 years, you should be the manager. Okay, you need to learn about how you're going to become a manager. Okay, and then the finance and accountant. Okay, you also have to become the financing managers and accountant. Sorry. And lastly, the marketing. So marketing is very, very important. Okay, if you don't have marketing strategies, so you are not improving. You're not going to improve your clinics. Okay, I give you one of example the marketing that we did. Okay, during my time. Okay, when we first opened our clinics, we don't really have our websites. Okay, and they don't know about our websites. What we did is that we go house to house to send pamphlet. Okay, and then we go to a local company like groceries, etc. We give vouchers, ticket. We go to like institutions like for example in Yunnan, you go to medical schools or you go to private schools. Okay, you send some pamphlet about your clinics. Okay, you join quite some events. Okay, and one of the successful things that we did is that we go to the kindergarten. Okay, we have a we have a talk with them. Okay, our target is not the kindergarten children. Our target is their family. Okay, we tell them these children have problems, health problem, and then we ask the patients, the parents to bring their patients to the clinics. Okay, and have a data checkup, and then from there we show our professionalism, the communication skills, etc. And uh, uh, I can tell you that this patient will come and become your patients. The whole package of family will come as your patients later. Okay, and you okay. So that's how you do some marketing. So you have to all have this in your clinics. Okay, 100% also administrative. Until now, everybody can follow my lectures. We are passing 30 minutes. Okay, so hopefully you understands. Okay, if you have any problem, any things, you can ask later after lectures. Now talking about policies. So if you are going to open your clinics, there are certain policies that you need to follow. Okay, first is the health agency, federal authorities, and also local authorities. Okay, who are those? Okay, now I think in Indonesia they have Dental Act, right? Okay, if you don't know, you can ask your lecturers there, your docent, right? Docent, right? Okay. Is there any Dental Act related to you? Okay. Developed by the governments. Okay. Private health first. What I put here is all related to Malaysian one, because all this when we open our clinics, we have to read all this act, we have to all these regulations, and we also have to obey all the rules that have been around. Okay, so we have the problems. Okay, like now we are extending the clinics, so with the new rules and regulations we have to follow. So we have to start with COVID. We start with the renovations, etc., etc. So we have to face all these things. Okay. You have to remember, when you want to open clinics or you want to do anything about the business, you have to know what are the agencies that born by you. Okay, born by you, mean that person that will always interrupt your business. Not saying interrupt. Okay, not interrupt. Sorry, someone who are going to like you need to make sure that advocate you. Okay, first is health agency. Okay, the act. Okay, so federal authority. What does it mean? Meaning that what are the rules that bond into you? For example, like code of professional conduct. You as a professional, you need, even though you're doing a business, you have to follow the code of professional conduct, the professional ethics that bond. Okay, that you bond to. Okay. For example, if you're wearing clothes, you have to wear what kind of clothes. If you treat patients, should you wear a slipper, or you should wear a shoes. Okay, something that covers your feet. Why? Because when your probe, okay, when your probe fall into your feet, okay, your foot, it is not contaminating you. Mean that it not injured you. Okay, that can cause other problems. Okay, resident safety X-ray. If you have X-ray in your clinics, so what are the safety that you need to look into? Needle pricks. Okay, I have been needle prick injuries. Okay, during my time. Okay, it's very we'll call it very um, scared. Okay, why? Because in my area that time, there are a lot. My boss saying that in that my area there are a lot of drug addicts. So drug addicts related to what? To HIV, right? So when there are cases that when you prick in needle prick injury, it can cause you might infected by HIV. So that time we are really worried. So we have been follow the procedures. We go to hospital, check everything. So alhamdulillah, I was free from the disease. Okay, alhamdulillah. So you have to know what are the steps and procedures related to you as you open your own clinics. Okay. Next is the local authority. Local authority is talking about when you open your own clinics in certain area, there are several things that you need to know, like business licensing, advertising board. Okay, if you want to put the board talking about your clinics, for example, like Gia Clinical Clinics. Okay, sorry, I know Gia better. Okay, I don't know others. Okay, so maybe Gia can come to Malaysia. Okay, visit my clinics later. Okay, advertising clinics. So you want to open your own clinic like Gia Clinics. So there are rules and regulations related to how you're going to open this. What are the things that you need to understand when you want to when you want to put this the advertisement in your clinics? Can you put advertisement to show the way to your clinics or not? Okay, all things is there is a rules that related to that. Okay, if you take one parking lot, okay, as your patients to come and they have treatment, so it's also some of the local authorities that are act or regulations that related to that. So you need to ask the local authorities, go to the office, asking if I want to open business in the area, what are the things that related to me. So they will give you a paper, so you need to read and understand, and then you have to comply to that rules. Okay. Now we go to the last one is a practice. We have to talk about people, policies, and last practice. So what are the practicing things that related to you and you have to put in your system? First is the leadership. I always love talking about leaderships, okay, because it's really important for you. Financing also is my favorite financing. Okay, when opening your clinic, you need to know the finance things. Okay, inventory, infrastructure, and also intelligence. Now looking about leaderships, okay, I have another 70 minutes. I try to make it on time. So leadership is what are the differences between leaderships and management. So I read some of the literature talking about the clear picture on how looking on management and so leaderships. Management is about coping with complexity. It brings order and predictability to situations, but that no longer enough to succeed. Companies must be able to adapt to change. Leadership then is about learning how to cope with rapid change. Okay, I give you an example. What is the difference between management and also leadership? Okay, if you follow the SOP, there's standard operating procedures. You are the one who are supervising the SOP. You are the manager. Okay, but if you think that, okay, there are some rules, not saying that you can skip. No, someone who are called to who not following the rules, okay, then the leader comes in. Okay, how are you going to solve this problem? Because manager say that, oh, you not follow the rules, you are not you are doing wrong, you're following the rules. This is a manager because they're following the rules. But leadership is different. Leadership is where you are going to motivate your personnel, your workers, or your employee to say that you shouldn't do this. Okay, what are the things that you need to say them to improve their standard operating procedures for them to follow. So that is a leader. Okay. So if you're managing, it's talking about planning and budgeting. The leader is talking about setting the direction. Organizing and staffing, okay, is the managing things. Okay, but aligning people to the direction is the leader. And lastly, controlling activities and problem solving is manager. Motivating and inspiring is leader. So I think you all have that in yourself. but how you going to polish it and show it to the others. That is the thing that you can learn and you have to learn. Okay, the skill is that self-awareness is part of the skills, knowing one's strength, weaknesses, values, drive, and impact on the others. Self-regulations, controlling and directing destructive impulses and moods. Okay, you are have that self-regulating. Motivations, you are the one who motivate people. You have the empathy, understanding other people's emotional makeup where they are in the bad mood. So you are the one to raise the moods. Okay, and you are having the social skills, building rapport with others to move them in design direction. So leaders have these skills. Okay. Okay. Now we're talking about finances. I have to go fast. Okay. 15 minutes later more. So what are the things in financings? Okay. I'm not talking very much into the financings. Okay. I'll talk about the cost later in the second lecture. But these financings, I just have a touch a very, what I call it, a very big picture. So if you want to know better, my advice is that you need to read and you need to experience it. Okay, you cannot just read without experience. You can be, better in knowledge, but you cannot be better in doing it. Okay, because I have because during my time when I was first working in governments, okay, I have experience having my own business. So that's why I always believe on finance is very important for you to put into. Okay, um, so what are the things in the financings? Okay, okay, this is terminology. When you read a lot of books, they're all talking about this kind of terminology in financings. First is revenue. Second is the reimbursement and remunerations. If you're working with the government, this is the terminology that you need to understand. Okay, what the financial revenue? Okay, first revenue is talking about the definition of it is that it reflects how the money gets into the system. For example, if you have your government, how money come into the pocket of the government. Okay, there are taxation, insurance, out of pockets, and donations. Okay, in healthcare, this is the four important things that relate to the revenue to the healthcare. Second, the reimbursement and remunerations is the mechanism of payment for services. Okay, meaning that if you have a clinics, okay, how does money come into you to the service? Fee for services, capitations, contract, also salary. So this is all the terminology that when people talk about and say that, oh, okay, how about your capitation? So this is all the things that related to the healthcare. So you might say, oh, this is what I learned it beforehand. So if you want to know better, you can read the Community Oral Health by Cynthia Pine. Okay, I think most of you have that. Okay, so for dental clinics, okay, fine dental clinic, there are three components that is very important when talking about financing. Okay, one, when you want to open your clinics, you must have a capital, or in Malay word is modal. Okay, modal open clinics. I don't know in Indonesian. Sorry, even though I have a root from Javanese and also from Minang, but I cannot speak Java. Okay, okay. So capital. Okay, capital means that modal. You must have that. Okay. Okay, and then you must have the operations financing. So you're going to operate. Okay, you want to do fillings, the tooth colored filling like composite, amalgam, etc. So what are things that you need to know when you do the operation financings? And lastly, the investment. The investment I will talk it later. Okay. So the most important things when you talk about financing is that I think most of you know the cash flow. Okay, cash flow is talking about the money in and the money out. Okay, or we call it as an income and also expenses. So if you want to know better, I think you might have another sessions talk about it. Okay, but this is how you're going to do your financings. Okay, when we first opened our clinics, okay, first opened our clinics, I have a friend, a very close friend during my schooling. Okay, he tell me that okay, if he want to help two of his friends who want to do business. So during that time, my wife want to open business, so we called him. Okay, the first thing that he taught us is the cash flow. You know what's cash flow? Okay, later you can ask your supervisor. I think most of your supervisors have done this cash flow. Okay, because I know that some of your have experience on businesses. Cash flow. Cash flow means that or how you're going to get the money and how you're going to expand. You have to the expenditure that you have in your clinics. No? So this should be balanced. We call it balance flow. Okay, money comes in should be more than the expenses. And you do the balancing account, you will know later. Something you want to know, you have to have another sessions there. Okay, So as very simple way is that money coming to you is income. Okay, when patients pay you for the treatment is income. The expenditure is money you pay out. For example, you pay for the human resource, the salary, okay, the material that you buy, the inventory that you buy, like for example, like all the equipment, the instruments. Okay, that is the expenditure. And also there is an assets. Okay, this two is something else. Okay, for example, if you buy your own building to become your clinic, so you have your assets. Okay, liabilities is cost you. For example, like your utilities. Okay, for example, like cars. Usually people say that car is the assets. For me, it's no. Car is liabilities. Okay, because the price is not is reducing, not increasing. Like assets, like you buy a land, you buy a house, it's always increased. So it's assets. Okay. Next is health inventory. Okay, talk about leadership. We talk about finances. Now we talk about health inventory. I cannot talk more. Okay, if you want, you can have questions later. Health inventory. What the health inventory? I will talk. I'm not talking. I will talk very short. Okay, about health inventory. Health inventory is the sorry, I cannot see it. The forecast, the procurement forecastings, the selection of materials, okay, budgeting, procurement, shipping, warehouse, distribution, and inventory control. Okay, for example, if you want to open your clinics, you want to buy materials. So if you have these materials, so how much that you want to buy, and that is appropriate for you to treat for the first 1 year. Okay, because I have experience, okay, during my time, okay, someone have buy a lot of materials. Okay, when I take back take control of the management, I found that the material they buy, the expiry is only 9 months. Okay, they buy it at the early of the year, but they're not using it, and the battery is expired, then you cannot use it. So this is called as a warehousing as inventory control. You want to inventory control, you have to remember that your material the expiry date of your material should be 2 years and not less than 1 year. Okay, because when you first open your clinics, you don't know the flow of patients to your clinics. So you have to remember that how I'm going to control the inventory, the way of I'm buying these materials, that is not exceeding the expiry date. Okay, if not, we call it as you're not working very wisely in buying the materials. Okay, so you have to know that. Okay, so all this is very important when you do the inventory things, the health inventory. Okay, buying things, everything. Okay, how you going to shipping and stuff. Okay. Okay. Next is putting to open your clinics. Where should I put my clinics? What are things that you need to do when you open your clinics? Okay, you have to know that where you're going to open it. Okay, if you usually if you read the literature, most of private clinics they open in the city. Okay, most of literature, even in the different country. Why? Because when you put in the city, okay, the flow patient is quite high, and the price that you put also, you could put the high price. Because why? Because majority of people who working in city usually is a high income people. Okay, that's why people always put open clinics in the city. But it doesn't mean that you should open city. You can put in the outskirt, but not in the rural area. For example, like in the middle of this city, and also the rural area. So usually, like my wife clinics, we open it just near to the just in between the city, also the rural area. And our place is very strategic, where our area is really close to the airport and close to the Kuala Lumpur. So people who work with Kuala Lumpur staying in our area, they will come to our clinics. Alhamdulillah, and our price also is not too expensive. And people from city, they can come to our places by 30 minutes. So it's very convenient and very accessible. Okay, and you also need to know what type of clinic you are opening. Okay, either you are going to high end, low end, or middle end. So you have to know that. Okay, and also if you open clinics, based on my experience, technology is very important. The e-clinical system. Why? I don't know. Okay, maybe you can start. Because we start our clinics with using the card system. Okay, like you record in the pen paper. But after 6 months later, we immediately use the e-clinical because it's easy, and you can manage all the account, everything in the one system. Okay. So last is it has intelligence. Okay, what that means of it has intelligence. Okay, don't just start by become a general GP. My advice, if you have money, okay, to further study, you have to become a specialist, because now in the future, I think in 5 years times, I think Indonesia also are going to be there. Okay, people are looking for specialist training. Okay, like here in Malaysia, specialist clinics is really become very prominent here in Malaysia. Okay, people are going for practicing specialists, and then they open their own clinics. Okay, evidence-based dentistry, always treat patients based on evidence. Don't think that what you have learned during your undergrads is still the same. No, they are advancing. So don't just be now, but be the future. Okay. Clinical data, okay. That's why I said e-clinic is very important, because everything is data is in the system, so you can do some projections and also planning to increase your profit later. If you don't have knowledge on business, you can always go to the business management course, okay, to improve your own self on how to manage things, okay. So, and lastly is the investment courses, okay. I don't know, I during my when I first graduated in dentistry, I really love into investment, but I don't have the risky things to put my money in investment. Okay, even though I learned about investment very, I know the graph, the investment graph. I learned from my boss those days, but I don't have the strength to buy investment. But if you have money, if you know better about it, go. Even though you have clinics, you cannot start with clinic. You have to go for investment. Okay, for other opportunity. Okay, now last one. Okay, we have another 4 minutes. Okay, very fast. Business strategy planning. Okay, after you have know everything, then you have to strategize your planning. Okay, what type of dental business that you want to open? Okay, when I always talk to my wife. Okay, if you want to open clinics, you have to know your business model. Okay, first type of business. Are you going to open your sole propriety type of business, partnership, and also corporation? Okay, you have to think, who are you, what type of business are you going to open. They all have their strengths and also their disadvantage. Okay, I cannot tell you now because we have a limit of time, but for me, if you want money more, you go for sole propriety because the money is yours, but the tax is really high. Okay, but if you want to have a big company, a lot of clinics, corporation is better because you have this the secretariat company to help you with the management things. Okay, what model business that you're going to open? Is it standalone? Okay, franchising? Okay, or data center? Like my wife, she opened data center. Okay, a lot of my friends doing franchising. They open their first clinics after 5 years. They open a franchise. A new dentist want to open clinics. They have model. They have the capital. So you have also capital. You put several percent for the capital. They also have their capital. So you're franchising. Like McDonald. You know McDonald. I think most of you know McDonald. McDonald is one of the business model of franchising. Okay. Always start with the end of mind. This is by Ibn Khaldun. If you read books by Ibn Khaldun, you will find this saying that start with the end of the mind. What does it mean? Is that you must have your visions and your outcome. A vision that looking at the outcome. You should know what you want 5 years later about your clinics. Okay, you want to have a profits or not. So from there, you're going to put your visions, your missions, your objective, and what the activities related that can achieve your outcome. Okay. Okay, then you must have a timeline. Okay, like ourselves. Okay, my friend saying that by 2 years you must have break even. Alhamdulillah, like my wife, after 6 months she have a break even point. Okay, alhamdulillah, because she's the first clinic open in our area. Okay, usually, okay, by 5 years you can see your profitable point. Okay, don't worry. Okay, if you want, you have to be in the area. Okay. Okay, about investment. Okay, there's several ways of investment. Okay, this is what I talk about investment. new business. Say my friends, they open after 10 years, after 10 years, having his own clinics, he have his boutique, he has his own resorts, and he owned a land of that like palm oil, everything. So don't start with dental business alone. You can have your investment. Okay, but money is not everything. Okay, put on your hobbies. Okay, if your hobby is traveling, you should put money into your hobbies. This is your investment. Okay, self-rewarding. If you think BMW is the car that you think better for you, can you open clinics? Self-rewarding. If you have that, buy a car for yourself. Don't start with the money you have to. No. Okay, if you don't do it, it's up to you. Okay, but self-rewarding. Families come first. Okay, go travel with your families. Okay, plan yourself to have a family vacations. Okay, my friends who open clinic always say that families come first. Every week, Sunday is his time with his family. Okay, don't work and avoid your families. Okay, and lastly, if you have extra money, or in Islam we have zakat, so don't forget to do it. Okay, donate. Okay, sedekah. Okay, do all the donations. Okay, why? Because donating money is not making your monies become less. No, it become more. Okay, so donate. Okay, as a conclusions, always plan in ahead. Okay, if you don't plan, you're planning to fail. Think big, start small. Always think big. You want to have a big company, but you have to start small. You have to have a start point. Okay, the mountains stabilize the earth. For me, it's fundamental. You have to learn the fundamental things. You have to work with the fundamental. Then later you can, when you have these basis things, you cannot the basis cannot fall your business. And lastly, my unknown future is in the hand of the all-knowing Allah. So pray to Allah to make sure that your rizki is there. Okay, I think that's all from me. Thank you very much. Go back to Dr. Dini.
Thank you so much for your insightful lecture, Dr. Azlan. We have a great number of questions for Dr. Azlan here.
Okay.
This is very good, and we still have enough time to discuss and answer all of the questions. But I see here that several questions have a similar topic, so I just try to summarize the question. The first question from our students, they ask about, is it possible if a dentist or a person play a dual role? I mean, like a person or a dentist act as a manager and also work as a dentist, or is it better to have a different person for different kind of jobs? What do you think?
Thank you very much for the question. I think it's really important things. Thank you. I think dentists become a manager. Okay, all dentists should hire a manager. Okay, based on my experience. Okay, if you talk to me, because I'm a dental public health. Okay, when you're talking to dental public health, managing is our bread and butter. Okay, I think you can ask Dr. Dini, also Dr. Taufan. Okay, we know management is very clear. Okay, it's our like butter. You talk about this? No, this is we know very detailed about it. But as a dentist, okay, am I going to be a manager? At the same time, I'm going to become a dentist. Okay, my advice that on the first 1 year, first 5 years. Okay, first 5 years, you have to become the manager. Why? Because you have spent a lot of money into your clinics. So you don't have enough money to spend to your manager. Okay, but after 5 years, you can think about it. Okay, if managing and doing a clinical things is really interrupt your work. Okay, because based on my experience, okay, with my wife, when she first managing the that's why she always consult me, because dentist is not, you're not learning about management. Okay, I have to truthfully, you don't learn about management. But when she first managing her clinics, haywire. Okay, haywire. But with the help with the consultant, okay, so I help her to put the account. Okay, I help her with the Excel accounting. Okay, how to put the money. Okay, how to make sure it is very convenient to see. Okay, the arrange sheet better looking. So and she also get help from dental students who waiting for job. Okay, and these fellas, the students really good in managing. Okay, he also show us the graph of profiting and also the other around the part which is not profiting. Okay, the graph everything. Okay, so simply saying that the first 5 years you need to become a manager and you have to learn. Okay, after that, if you not if you open a clinic not as the sole property, if you open as a corporation, there is a company. I don't know in Indonesia, I don't know, but in Malaysia we have a, if you do a senior berhad with corporations, we have the secretariat to help us with the management. Okay, they will help us with the what call it, like human resource, the paperwork, but we have to manage them. Okay, it's up to you. Okay, I cannot say that because some of you may have that managerial skills and they have really have a leadership inside them. The thing is that they just polish it, but most of you might need to learn about managing. But part of it, 30% is managing, you should have 70% is clinics, is on you. Okay, learn, because when you learn and you experience it 5 years, then later if you want to do anything, it's up to you. Is it clear?
Okay. Yes, I think it's clear. It depends on if we have managerial skill, it's okay if we become a manager. But if not, we should learn first, or we can hire someone who have expertise in management system. Right. Okay, thank you. Maybe the next question I will invite Dr. Zamzam, who would like to ask you directly a question. Dr. Zamzam, can you unmute yourself and ask directly to Dr. Azlan?
Thank you, Dr. Dini. Assalamualaikum warahmatullahi wabarakatuh, Dr. Azlan.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you for the wonderful presentation. My name is Zamzam. I want to ask you about the research-based dental clinic management. How research can improve dental clinic engagement to market? And as we know, there are several kind of research such as service quality assessment for patient satisfaction and etc. And what kind of research that can be an option to conduct for non-researcher dentists or full-time practitioner without any sufficient research skills? Thank you, Dr. Azlan.
Okay, thank you very much, Dr. Zamzam. I assume Dr. Zamzam is now a dentalpreneur? No?
Some of.
Wow. So the lecturer, your lecturer in UNAIN, is it?
I'm a junior researcher, sir.
Oh, okay. First question is about research related to dental business. Okay, or is there any things that the dental practitioners working in the private that can pursue for the research? Okay, the first of research, I think there are a lot of research that related to dental business. Okay, one of my intentions of doing business is to have a module, okay, to help with the undergraduates on what are the things that related to them that will help them to work when they graduated as a dentist. Okay, what are the things that they need to prepare before they come into the real world, okay, out there. So that's one of the research that you can do, making a module. Second, the things that you can do to database is that like looking into the every single part that related to the dental services, like what are the appointment things that related to the patients. For example, like how many patients have not turning to the appointment, okay, fail to attend the appointment. Okay, I'm doing my study on that kind of things. Okay, the flow of patients on appointment. Okay, what are the things that patient fail to attend the appointment? Is it the patients or the dental practitioners? Others like you said, satisfaction. Does patient satisfied with your work? Okay, or if you want to go further into the business, maybe you can see on the financial basis. Okay, what are the financial things that related to dental business? How dentists, okay, operate their clinics on the financial work. Okay, do they know about the financials or not? Okay, and you also can have the corporate the collaboration with dentists and also the financial the economics faculty. Okay, they know better. Okay, and they know, or you want to go furthermore on the policies, you can go for the what we call it as a costing analysis, cost effectiveness. All these, a lot of things. If you if you read a lot of literature in that kind of area, you know a lot. Okay, I learned if you want, literature can help you. You can put data business or cost analysis. All this can come up with a lot of things. Okay. Second, about what are the research that the dental practitioner can do. Okay, I don't say it's a research. Okay, I always believe that if you are dental practitioners, you can always do an evaluation. Okay, evaluation is the wonderful word. Our dental, we as the public health always talk about evaluations. Okay, what does it mean of evaluations? When you open your clinics, you must have a plan and you must have an outcome. Before you come into your outcome, you must evaluate every single process that you do. Okay, it's called as a research. Okay, people say it's research, but for us we call it as evaluations. You have to evaluate. Okay, for example, if you plan, you must have by 5 years your income must reach 50. How to say? I'm talking about ringgit Malaysia. If 50,000 Malaysia ringgit, how much is in Indonesia? Sorry, Dr. Dini, can you help me? 50,000 converted to Indonesian, how much?
50,000. 50,000 what?
Ringgit Malaysia.
Ringgit Malaysia. I will check. Okay.
Okay. I just continue while Dr. Dini searching. You want to achieve 50K by 5 years every single week, every single month. Okay, but you cannot achieve it. Your highest is about 30,000 ringgit Malaysia, for example, 30K. So why I cannot reach that? So then you have to go back to your process. That is research. You have to look back. Which part of your things that causing you not reaching the 50K? So Tini, how much is that?
It's the around of 17 million, sorry, 17 million and 7,000.
Okay, like my clinics now. Can I impose here? Expose? No, no. Okay, okay. Like my wife clinics. Okay. She have. Sorry, I cannot say my wife clinic. Okay, I say about my friends. Okay, my friends clinics. Okay, he has 3 clinics doing specialist work and also the normal work. For the normal work, he achieved 1.5 million Malaysian ringgit. Okay, you must have that in mind. Okay, you have to target that. Okay, why? Because you target that, you will work for that. Okay, 1.5 million Malaysian ringgit. I think you can check it how much is in the Indonesian currency. So how he achieved that? So he did a lot of research. Okay, if you find no cannot. Okay, what are things that you related to that can to reach that? So if you do research, you must always put objective. So objective, you cannot reach that. What are the research that you need to do? You get that, Dr. Zamzam? So always have your objective and your mission and your outcome, what you want. So from there, if you don't achieve, then you do some research on to identify what are the problems that related to the goals that you want to achieve. Okay, I think that's my answer.
Yeah, thank you, Dr. Azlan.
Okay, you're welcome.
Okay, thank you. The next question is also from our students. It's about dental advertising or dental marketing. The student asks about, is advertising ethical for dentists?
Sorry?
Is advertising ethical for dentists? Because
Oh.
dentists may need advertising their dental practice, but is it ethical for dentists to advertise their dental practice?
Okay. Thank you for the questions. Yes, I think this is. Sorry. Before that, I'm sorry because I have to ask twice because I'm looking at the Zamzam picture. Sorry, he's really handsome guy. So talking about advertising, there are a lot of okay. Are you ethically doing advertising? Is it ethical or not? Okay. It depends on the countries and also the province. Okay. Like in Malaysia, you can advertise, but there are some rules that you need to adhere. Okay, what does it mean? For example, this because when I handle when I taking a task to become one of the quite as a director of the private wing of data clinics in our university. One of the things that my boss always, because my boss is an ex director of healthcare during of the national healthcare, so he said that if you want to advertise, you cannot overclaim. What does mean overclaim? Okay, I give you an example. For example, you do whitening, okay, tooth whitening, okay, before and after. Okay, usually now people always have this photography. You take before treatment and after treatment, right? I think you learn about it. Okay, when you take the first treatment, okay, the first color of the tooth is really bad. Okay, they are discolored. It said, for example, like it might be B3, okay, B3 or C3. Okay, and then after treatment, you found that wow, it's A1 or A2. Okay, and you put into the advertisement. You said, this okay, you get treatment from us. This is the treatment, the service that you can provide to you. No, you cannot do that. Why? Because okay, I'm talking this one ethically. You cannot do that because some of the rules saying that you can overclaim. But for yourself, okay, for example, if you treat a patient, because I talk it based on my experience, okay, handling or managing all the clinics, patients came back. Okay, after 3 days, you do the whitening. Patient came back. So that I don't satisfied with work. Okay, why my teeth go back to the for example like B3 A1, now I get A3. Okay, I don't like it. I want to refund my treatment. So it's go back to you. Okay, what the best way on doing it is that you don't overclaim. For example, if you have A3, you can go to A1. B3, you get to B2 or B1. If you overclaim, it will risking your own practicing. Okay, not only the advertisement, but also risking yourself, because when you do something bad happen, then you can be refunding the patient's treatment again. So for me, it's ethical. It's not. Is it ethical or not ethical? It depends on the province. But again, you have to, because you are the one who are the practitioner who know better about your treatment. So don't overclaim. That's all. My things. Don't overclaim and don't put discount. You are professional. Don't discount your own self. Okay. For example, for example, other place you put hundred. For example, like 1 million for several treatments, and then okay, I'm giving discount. You put on your advertisement 60% discount. No, don't do that, because you are risking your own professional, saying that there is a discount. If you want to give discount, okay, patients come into your clinics, talk with him, talk with her, then okay, I will talking about cost later. Put all your costs, and then maybe you want to have a less profit, then you give discount. Don't put advertisement for discounting the treatment. Risky. Okay, that's all. Thank you very much.
Thank you, Dr. Aslan. I think it's also clear. And maybe there's also another question, and there are many questions.
No, it's okay. It's okay. I love it.
Chat box. Yeah, but it's similar also. So I just summarize.
Okay.
It's about how to manage our dental practice during this pandemic era. So how to balance between our income and our expenditure regarding the PPE and so on.
Oh, very tough question. Really, very tough. um, okay. Again, based on my experience and I think based on reading everything. Okay. When the first pandemic hit the world, okay, all country really depressed. I think the most depressing persons I can say is that the private sectors, including my wife. Okay, what we did. Okay, I don't know in Indonesia, but in Malaysia, what we have been given during the pandemic is that the government is really generous. There are a lot of what I call it, the incentive that they given to the people here, and I hope that Indonesia also doing the same thing, because I heard a lot of I know internet sometimes it can be true, can be not. A lot of issues related to Indonesia, but I hope that Indonesia also will get better and better and better, because we are always the same people. Even though I speak English, I always say that why I cannot speak Indonesia. Okay, what you should do? Okay, first you have to adhere to the rules regarding the pandemic. For example, like the PPE, like the double gloving, sanitizing. Okay, even though you think that that will cost you a lot, don't worry. I can say you don't worry. Sometimes when you do good for your for your client, actually Allah will do good for you, do good back to you. Okay, like my wife, when they first hit the clinics, okay, we have to reduce the number of our workers, okay, from 4 become 2. But because we always paid for we call it so something like what do you call it, a payment that will help these workers when this kind of thing happen. Okay, then my wife go to this SOCSO, we call it SOCSO, these organizations, asking for money to help the person that the workers, the employee that we have to put them on holiday. So they not coming work, but they got salary. I don't know how in Indonesia, but you need, what I say is that you need to, for example, when during your supposedly during when you open your clinics, you need to put aside some money for call it for this kind of emergency. Okay, don't just spend all your money for whatever you want. No, you have to always remember. If you we're talking about, Joseph, the prophet Joseph, okay, the seven years and 7 years, the 7 years of victories and 7 years of the problems. Okay, he always put some emergency for the 7 years of the problems, like now. Okay, all the way to that. Okay, I don't know, I don't have solid answers for that, but it is you have to follow the rules, but you also have to have the contingency plan. And I always because it hit me now, it hit me again. Okay, so I always prayed for all of you that you can manage well in your clinics. So that's all my answers. Hopefully it's clear.
Maybe it depends case by case
True.
for the dentist themselves. Okay, maybe will be the last question from our lecturer in dental public health department. It's still about the ethics,
Okay.
but the question is related about the telemedicine or teledentistry. What is the lesson learned about telemedicine fee and ethical consideration in this pandemic era, particularly about online prescribing?
So mean that you asking for fees for the telemedicine, is it?
Yeah, we use telemedicine or teledentistry right now. How about the ethics consideration for doing teledentistry, particularly regarding online prescribing? So we give prescription for our client using teledentistry.
Oh, I'm not clear with the questions, but I try to answer. If it's not answering your questions, you can always
okay.
Correct me. Okay, telemedicine. Okay, I think telemedicine is now I not only in the pandemic era. I think those before the pandemic era, telemedicine also have their own strength during that time, because I read a lot of telemedicine, and also we also did some telemedicine research. Okay, the ethical things about telemedicine is that I think there is no such thing. Sorry, I'm sorry. There is an ethical things about telemedicine, but adhering to the ethics that related to it. For example, like the rules of doing the telemedicine. For example, if you do like a surgery, surgery of patients on telemedicine, always get consent. Written consent is really important. That's my first point. Okay, why? Because sometimes when you don't get their consent, okay, for example, like you put them on to sleep, you do general anesthesia. Okay, patient don't know what happened to them. Okay, then you do some telemedicine and then you put into online or do something of online work. Okay, later they found that, oh, my me is in the online. I feel very depressed, so they can sue you actually. That's why I always go for consent. That's why I think public health always talk about consent. Informed consent is not enough. If you go online, you must have written consent. Written consent, because why? It's recording. If you go to court, you will win the case. Written consent. Okay. Informed consent also good, but I don't think telemedicine, if you do not have a live surgery things, if you have like this kind of things, so informed consent is, I think, is enough, but better to get a written consent. I think good to have to do the medicines. Okay, I think it's better during the pandemic. Okay, adhere to the act, also the I think the professional conduct. I think all countries have that. Like us, we have the professional conduct. Follow that rules, then you are going to be okay. Okay, is it Dini, Dr. Dini?
Maybe the question that have not been answered yet
Okay.
is it okay if we provide prescription online?
Provide prescription. Prescription
Yeah,
online.
prescription, yeah,
Drugs prescription, is it?
yeah, drug prescription.
Okay.
If the client needed.
Okay. Okay. If you have, for example, generated one, for example, like with I don't have the experience of handling this kind of case, but what you can do is that if you have these prescriptions with your and I cannot say that, very difficult one. Okay, if you have these kind of things, like you have the system, okay, usually I think the telemedicine prescribing online really is difficult to say, because it depends. For example, like in Malaysia, if I'm Malaysian and I work with Indonesians, okay, sometimes my prescription is not what call it, laku it's not cannot be used in Indonesia. Okay, that's one of the things. Unless our country, for example, we have a MOU with like apa ni, work collaborations between these countries, and we have this like this can be used in your countries, that is okay. But if not, I think ethically it's not values in your in doing that. Okay, Dr. Dini?
Okay, I think again it's clear. Okay, I think that's the last question, Dr. Azlan, because we already run out of time for this the first session of our today's webinar. So I would like to say that it's interesting for me, for us to hear our discussion about this topic. Okay, do you want to have a break, a short break before we start our second session?
I think I can. For me, I can continue, but I just want to have a sip of water. Is it okay?
Oh, that's all. Okay. That's all right.
Okay.
All right.
I'm back.
Okay, thank you, Dr. Azlan. Okay, for all participants who may just come to our webinar today, this will be our second session of our today's webinar. So I would like to introduce our speaker. He's after the first speaker of our today's webinar. His name is Dr. Azlan Jafar. He is a dental public health lecturer in University Saint Islam Malaya in Malaysia. In the second session of today's webinar, Dr. Azlan will give us a lecture about dental clinic cost management system. Maybe you can start your lecture now, Dr. Azlan. Thank you.
Okay, thank you very much, Dr. Dini. So I'll share my slide now. Okay, can you see the slides, Dr. Dini?
Yes, it's clear.
Okay. Bismillahirrahmanirrahim. Welcome back again to my sessions talking about dental clinic cost management system. I think this is my my close to my heart, because when I first handle when I first manage my first task managing the private clinics, I'm doing this dental clinic cost management systems. Okay, it's because we have learned during my undergraduates. During my postgraduates, we learn about costing. Okay, what are the things related to costing. So when I been given the task, so the first thing that I did is I did the costing. So this most of the time is my experience I want to share with you, okay, with all of you, because sometimes when you put the price of your treatment, sometimes you don't really look into the cost. Okay, what you do is that you follow your friends. For example, like, what other clinics putting their price. Okay, but you and them might be different. For example, like maybe your model business is different from what their is. Okay, for example, you are doing the high end type of business, but they are doing the low end of business. So the cost is different. Okay, so you are really need to understand about the cost related to that to your costing, to your pricing, so that you are not putting risk to failing your own business. Okay, your own dental business. I say that. So now, as we know that, sorry, I have to. Okay. Okay, estimating the cost in dental care is and its annual increment in mathematically challenging. It's very, very challenging to put cost to your price and substantial empirical undertaking in the absence of routine cost data, because we don't have that knowledge of doing the data cost analysis. Okay, analyze your costing. So it is not like, for example, that's why when we first opened my wife first opened her clinics, she always referred to other clinics to compare either it is okay or not pricing that to your patients. Okay, that's why sometimes you don't know, then you follow what are the other people doing it. So for starting from today, what my advice is that, because you learn it and I giving you, okay, usually okay, now we are doing a module on what I call it, on costing. So the next future, okay, if you want to call me to do costing, okay, they are going to charge you, okay, for that for this Excel that I given to you. Okay, so for time being, I give it for free to you all. Okay, feel free to use it. Okay, and then don't worry. This actually will help you. I think for the first time, it'll help you to do pricing. Next time, maybe you can put the things that you found it is important for you to charge patients. So you can put inside there the data cost, the Excel costing that I've given to you. Okay, so sometimes we demonstrate a best practice pragmatic approach to estimate the cost according to the common practice in cost analysis. Sometimes you, as I said, if you know better, then you do the data analysis, the costing things. But if you not, you always follow the others to do it. Okay, and when you have these kind of things, if you routinely use these kind of things, you put some input, you do some extra work, and then you practice it, you experience it by your own, and you know how much you can cost. Okay, and then comparing to the others, the current price that you have, then you actually know how, for example, if you want to put some give some like some discount later in the clinics, it's up to you. You can actually do it. Okay, so you can have this practice and you can become the best practitioners in doing the data costing. Okay, some clarification. Okay, if you read some books, there are some clarification of costing. Okay, this one is I read it from WHO. Okay, my friend's doing data cost analysis, so I'm using her book to refer to. Okay, there are several there are two kind of classification. One is by input, another one is by output. Okay, but this one is more on input. Okay, and majority of I think business, they are using this kind of cost. First is called as the capital cost. Okay, what are the capital costs? And also the other one is the recurrent cost. Current capital cost is such as vehicles. If, for example, if you have a clinics and you have a vehicles related to the clinic, for example, like you go for like use it for office work, so you might have a vehicles. Equipment such as dental chair, autoclave, okay, etc. So this is also a capital cost. Means that you paid once, and then you have to pay. You have to calculate what the cost for that that equipment. Buildings, if you buy that buildings, you put it as a capital cost. But if you rent it, you put under the current cost. Training for non-current for training, such as for example, like if that training is once a year, so you put it under capital cost, of course, because you don't have it every year. For example, like family day can be a capital cost, okay, because you don't do it annually, okay. And lastly, social mobilizations. And so it's also like the program that you did once a year. Okay, for current cost is you call it a personal cost. For example, like if you you work as a dentist and a manager, so the salary for you, okay, is a recurrent cost because you pay every month or every week. Okay, supplies like the materials that you buy, like composite amalgam, like the whitening materials, all this is supplies, is a current cost, recurrent cost. Okay, something about of vehicles that you use it for operations, and the building for operations is and the maintenance is called as a recurrent cost. And also training, recurrent training, for example, like every week you have this course, for example, like this kind of online course, or you have a business management course, everything which is recurrent things. So it's also called as current cost. Okay, like my wife, what we did is that we have this we put as an overhead like or current cost, recurrent cost. For training is that every single dentist will be provided 1,000 a year to go for training. So if it's exceeded 1,000, you have to pay by themselves. So 1,000, we allocate money. So that is in the current cost. So you have to give if you have a dentist, okay, in your places, in your clinics, so you have to give them a opportunity to go for training, okay. And also social validation. If you go out for programs like oral promotion, educations around your area, so this also is a current cost. If you go every week or every month. And other operation costs, I think you know better because you are the clinicians. You should know what are the other operation costs that included. Okay, for costing analysis, okay, if you read a lot of books, textbooks, and also literature, there are three common type of costing available in the in dental health business. First, we call as the activity-based costing. This is a very common one, and I really love it. I use it. I use this activity-based costing, and I will show you how to do it today. Top-down costing, so, meaning that you put the price first, and then you put into the details later. Lastly, is the clinical pathway costing. Clinical pathway costing actually is the best for the hospital or the training center, institute center like Unite, okay. Because it is more on the evidence base and also the best practice management. Okay, they call it as a clinical pathway costing. Okay, I will touch a bit about clinical pathway costing, more on the benefits and the principle of doing it, but I'm not going to teach you on how to use this kind of clinical pathway costing. Now we're going directly into costing. Okay, ABC. I'm worried that I'm going to extend. Okay, I just want focus later on the Excel that I given to Gia. Again, maybe we're going to share it later on how you're going to do costing by ABC. Okay. So now we're going to the definitions. Okay, what is ABC? It's a method of allocating costs to products and services by assigning costs to all the activities. Okay, remember all the activities. Okay, to use to create these products. For example, your services. For example, you're going to do some restorations, tampalan gigi. Okay, so what are the activities related to that tampalan gigi? Okay, to the restorations. Okay, so that's called as a ABC. Every single activities, either you talk about the salary of the doctors, the material involved, the utilities, and others, the capital and also the current cost is ABC. Okay, so it's really the level of effort for the resources, okay, to perform the given task. So for example, like when you do that treatments, okay, of that treatments, okay, the person doing the treatments, okay, is counted. Okay, this level of effort is typically calculated using an algorithm derived from the expense analysis of the cost and time drive that affect each activities. Okay, every single algorithm, so like the formula, okay, should put into that costing. Okay, and after calculating the efforts, okay, for example, in work hours, like mine, I will put it into minutes. Okay, one can derive cost for that specific task by factoring in the hourly cost of the persons who perform that work. Okay, okay. Why later I will talk about the minutes, because why I'm talking about minutes, because usually when we do certain treatments, okay, you have to I just give you tips. When you do treatments, you should plan your treatments. For example, if you think that you can do tampalan gigi for 30 minutes, sorry, for example, during your undergraduate time, maybe it took you around 50 minutes. Okay, so my advice is that you should try to work under 30 minutes. Well, sorry, under 45 minutes, because most of the literature that I work with, I read, the best period for doing treatment, the basic treatment is 30 minutes. That's why okay, if you remember, Dr. Zamzam asked about satisfactions. One of the factors that when we search during our research is that the time factors, okay, the period of factors, the period of treating patients. Usually now in Malaysia, the government put the KPI, the key performance indicator for treating patients is 30 minutes. That's why in my slides, in my Excel, I put that I times to 30 minutes. So I will talk to you later. So you have to try to perform yourself to treat patient within 30 minutes. You can have 45 minutes. Is the moderate times. If you more than 45 minutes, so you are taking a lot of times treating your patients. Okay, what are the principles? Okay, it's the activities. The activities are the cost drivers. Okay, that activities must consume resources to product output. So that activities that you put in costing is something that you put that can that involve in your outcome, the output that you treat. Okay, each of these must be identified. You have to identify all the activities. If you do treatment, that treatment, all the activities that you need, you have to jot down. You have to detail up. Okay. Every resources used by a specific patients are recorded. Okay. So if you use, for example, like you use gauze, I using the English words gauze. You use probe. You all use this. You have to, or you autoclave all these things. You have to put into your account. Okay. Don't left any of the details. So what are the advantages? Okay, it's produce a comprehensive costing data set. Okay, very comprehensive. Okay, yeah, I will show you. Researchers understood the process of care, so you know which area that not that is a problem that you need to look into. Okay, you have to evaluate. Okay, and identify interpatient variation. So sometimes some patient you might not use this kind of treatment equipment, but this kind of patient you might use the treatment. Okay, so that's kind of thing you need to. They also will tell you in the ABC. Okay, so what does this just require more intensive primary research? So you don't have much time to do it. Okay, if you open case, what you want to do is that you want to get money. Okay, so it's very intensive. Okay, slow and more expensive. Sometimes people feel it's very expensive, but no, if you don't cost that, how you want to get the best price? Okay, need properly trained staff. Okay, this kind of things is true. So if you don't understand about ABC, you cannot really do it. Okay, need good. This one is for hospital. You must have a health information system. If you got this system, actually you are helping you, but you don't have that. Disadvantages for you. Not necessarily accurate. Sometimes you might left certain things that you think it's not important, but you don't put it into your cost. So authors may change their behaviors, and not all costs are visible. So sometimes you cannot put into. For example, one of the research saying that how about the CEO? For example, it's a corporation clinic. So you hire a manager. This manager you pay them very high price, high salary. So sometimes this kind of thing you cannot put into your cost. Okay. So what's the limitations? So this is one of the limitations. Okay, this kind of business sustaining things. So the executive one, how much you pay and can you put into your cost? Okay, so it's something that you have to ponder. You have to think of. Okay, now we're going to look into the process of doing it. So this is this lecture will be quite short. We're going to look into one by one in the exams. Okay, ABC methodology. What are the methods involved? First is the dental procedures. Okay, you need to know what dental procedures that you're going to do. Okay, and then what are the dental billings that involve? For example, like the electricity, the water, the sanitation, etc., and also the staffing. Okay, what the personnel that working with you that you need to pay the overhead. Okay, and then the per itemized. So for example, like the direct labor costs. Okay, for example, you paid for the outsource. You outsource your dental technician. Okay, your denture you send it outside. So this kind of labor costs. And then the equipment. Okay, what are the equipment that involved? For example, like your dental chair. You have, for example, you have dental chair, but you have another, like for example, like surgical motor. Or for periodontists, maybe they have this their surgical cautery. Okay, or maybe orthodontist. Okay, what are the equipment that involved for the orthodontist? Okay, so all this is equipment that involved with the treatment. And lastly is a material such as amalgam. We have the capsule, and you also have the vibrating machines. For arginates, maybe you have like you have to buy if you are very advanced technology, you buy the machines that you just put into the machine, then they will pour it for you. So all these kind of materials and equipment actually rated, and you have to count it in your cost. So we're looking at some of our examples. Okay, staff costs. Okay, the emolument. Okay, the cost calculated based on emolument. For example, like you paid. Okay, I'll show you later. Okay, of each category of staff, including salary, allowances, overtime, and bonuses received in a year, and then you divide by 12 to get emolument per month. Okay, so you calculate the year, the emolument for the year, and then you divide it by 12 to get per month. Okay, and then monthly income divided by 10,560 to get staff cost per minute. Okay, so this is how you calculate it. Okay, to get the price per minute. Okay, so then you put into the tables. Okay, you put how much is the salary per dentist, how much salary for the manager, how much salary for the counter staff, and the DSA is the dental surgery assistant, the person who assists you in the clinics, in the surgery room. And then how much time they spend. Okay, this is very, as I said, how much they spend for the treatment. So is it 1 hour, 30 minutes, 50 minutes? Okay, and then you get the total cost. So second is a capital cost. Okay, capital cost usually this is more on the building. This one is more on the hospital or someone who have data center that they buy the building. Okay, if you rent the building, that's something else. Okay, so for building usually they have this we call it I can't remember. They always the recessions of the building. For example, like the price will be high, but the building itself, maybe they have a problem with the what they call the building itself. Okay, so this should be counted to calculate the building half life. For example, if you talk about drug side, they have half life. Okay, so usually for hospital based, they're using the 5% rate. Okay, 5% discount rate. Okay, and then they calculate by within 20 years. Okay, for furniture equipment, usually 5 years. So why you calculate 5 years? So that you put into the cost, and maybe after 5 years you change it to the new one. Okay, and you use annualizing factors to determine cost per year. And then these costs are further divided by the total number of patients treated for a particular year in order to get unit cost per. So you have to count this into your cost of treatment. Okay, you don't miss this kind of thing, because sometimes people only look into the materials and the patient, the person involved, but they don't count the other, like this kind of building. Okay, this is an example. For example, like if you buy the building 10 million. Okay. Malaysia, so sorry, because I'm using Malaysian currency. So then you counted by 5% per annum, your discount rate. Okay, annualization factors. I'll show you later in the slides. Okay, how you got these annual factors. 12.462. Okay, this is for 20 years of life of the building, and then divided them, and then you got the cost of the price of the building, and then you need to determine to the per minutes. Okay, you count this and per minutes. If you buying the building, if you're rental, that's difference. Okay, next is regarding the cost of different inputs. Okay, what are the inputs that involve? Okay, sometimes you might have vehicles, I mentioned earlier. Okay, the distance travel, time use. Usually this is more on the government, because they're using for example, United, they have a van, or they have a bus for you to travel the students to the programs. So this should be calculated in the cost. Okay, equipment. Okay, how time use. Okay, how long the period they use for example scaling. How much you use the scaler to scale to do scaling. Okay, building. Okay, you also need to segmented your area. Okay, for example, if you if your space of your clinics, okay, for example, like 360 meter square, so and then you put your clinics, your surgery only around For example, like 20 meters square, you have two dental clinics, two surgery, and you have a counter, and you have the living area, the where the patients sitting waiting for the waiting area, so where the patients waiting for the treatment. So all spaces that we have, you have to count. Okay, you feel like, oh, very detailed. Yes, you are very detailed. This time when I learned this one, they're using it for hospital. That's why when the doctors does not perform, they don't have much patients. That's why they put appointment for the doctors once a week. But if that specialists have appointment very often, for example, like every week, so these doctors actually give money a lot to the patients. Okay, sorry, to the organizations. So that's why how you count the performance of the doctors. This is how you can do. For example, like in Malay, in our area, our places, the highest number of specialists in our is the orthodontist. Why? Because they make money. Okay, that's one of the reason. Okay, staff, time work. Okay, for example, like 8 hours a day. Not but OT is different time. Okay, if you staff, okay, usually you have a compulsory working hours. 8 hours or 12 hours, I don't know in Indonesia, like here in Malaysia, 8 hours, the rest is the OT, okay, the overtime. Supplies, the volume and weight used. So you have to know how to use it. For example, like if you do have what I call it, the composites, okay, usually composites come with the tube. Okay, how you want to count the price of the cost of the composite. You have to I will tell you later, because this is what we have a very good discussion about the composite. So the examples, okay, so everybody ready for me to share on the ABC costing methods? Okay, okay, this can you see this Excel? Dr. Dini, can you see the Excel?
Not yet.
Oh, okay, so I need to
Yeah,
unshare and share back.
yes.
Okay. Can you see now?
Yes.
Okay. So this is Excel. I do it myself. Okay. So please use it wisely. How to say? Dr. Lee, can I say this? Do not share to others. Can I say that?
Yes, you can say that. Please don't share.
Oh, okay. Okay. For the time being, please don't share, because if not, it's back to me, because I'm the one who giving it to you, because it's actually what call it? It's what call it? Very private. Okay. So hopefully that you can use it, you can try it, and you can use it in your clinics. So
Don't worry, Dr. Aslan, we didn't share this file to others.
okay, thank you very much, Dr. Dini. I adhere to your promise. I trust you. I trust all of you. Okay, okay. Now we look one by one. Okay, when you do all the activities, okay, the first thing that I count before I do my activities is the examination sets, because the first thing that you always do, even when you consult patient, is this examination sets. What are those things in the examination sets? Okay, we have pouch. The pouch is that when you want to sterilize, the plastic cover it is the pouch. Okay, I think you all know the cotton roll, the cylinder, what do you call it? The cylinder cotton. Okay, the gauze, the cotton pellets, the glove, the gown, and the tissue, even the tissue. Okay, okay, put inside the examination set. So all these should be counted this detail. Okay. I think some of you, wow, it's very detailed. Yes, this is detailed. Okay, I count it one by one. So per unit, per pouch is, because this is based on the price that I bought it during my time. That one is 2017. So I don't know now the price is how much. Okay, so you can always recalculate it back. Okay, how I use it. Okay, first, okay, you buy in the bulk. Okay, this pouch usually in the they come with roll. Okay, so the first roll maybe around how many meters, I cannot remember. For example, like maybe 100 meters. Is 100 meters? For example, 100 meters. So 100 meters, how much do you use for elevation sets? So you cut it, you usually around 90 cm times 90 cms. I can't remember, okay, exactly. So 90 cms, you divide it 100 meters divided by 90 cm. So how much that you can use for that 100 meters. So that 100 meters, okay, then you count it, the price, you divide by what call it, the use the length that you use. Okay, then you get the price. So like this pouch, I got 23 cents. Just I'm using measuring it, so you can transfer, you can convert into your currency. Okay, so all this, then you found that the price for elevation sets involving all this kind is 4 ringgit 98 cent. Okay, because why are you using? Because this is usually you're using for consultation. Because when you consult patient, the first thing you need to do is examine the oral health or the oral of the patient's oral cavity. Second is the item, the basic treatment sets. Okay, what are the basic treatment sets? Okay, like for example, like when you want patients to spit into the stool, you must have disposable cup. You have a bib to protect the patient's clothes, okay, and also suction tip, okay. If you have others, you can put into it, okay. So you also need to count it by per unit. For example, one cup. For example, if you buy a carton, maybe they have around maybe 1,000. So 1,000 price around, for example, like 100 ringgit. Okay, then you have to divide it, so you get the price maybe around 100, around 10 cents. All this should be around measure 0.4. Okay. Lastly is the dentist. Okay, so the stuffing, okay, the human resource. You also need to calculate it. Okay, how to calculate it? Okay, the formula is that it's an average. Okay, average treatment per staff is around 30 minutes. So for per patients, you treat them. As I said, you have to treat them. The optimum period is 30 minutes. If you more than that, so you have to count by 45 minutes. Okay, so then you get the price per session. So 30 minutes. So the price for dentist based on the formula is 15 ringgit. Okay, you can count that for this. Okay, so 15 ringgit per day. 15 times how much? 8 hours. So 15 times 8 times 2. Why? Because we're using as a half an hour. So an hour is 1 hour is 30 ringgit. So 30 times 6, so 240 ringgit a day. The salary for dentist is 240 per day. So all this should be calculated, and then you have to put into the costing of the treatments. Now we're looking at the basic cost capital. So all this, okay, why I don't put all this, because it's very tedious to do. Okay, I just give it to you to do it. Okay, you can always improve my Excel work. Okay, this is basic cost for capital cost. I put capital cost, but sometimes they also it's a recurrent cost. First is okay. For example, like building rental, actually it's a recurrent cost. Okay, if you buy a building, so I call it as it's assets for the building. So how are you going to calculate it? Okay, for example, if you use rental, for example, per month you paid around like my wife, the price for the building is around 6,000 ringgit. So 6,000 divided per day. Usually we work around 22 days per week. This is a compulsory one. If OT, so it's around 25 days or 26 days. Divide by that, then that is a cost for it. And then you have to times also the minutes and also the hours. Okay, divide by that. So you got the price per minutes. Okay, and then the dental chair, X-ray machines, autoclave, and others. Okay, all these should be included in your items, and you total up everything. Okay, because I think you're using the you cannot miss the building, right? Because you not treat patients on the field, right? I hopefully that. Okay, dental chair. Okay, you might have counted the dental chair. Okay, in your maybe the price, it depends what brand you use. Okay, for example, if you do ADEC, Malaysia ADEC, the basic one is around 30 to 50k. So like Dr. Dini said, it's around 17 million. Indonesian dollar and Indonesian rupiah. So all these should be included. X-ray machines, if you're using lateral cath or using OPG, or if you're using only periapical X-ray, you have to include it. Okay, how frequent you use it. Okay, and others. Okay, next is the utilities bills. Okay, the electricity, the water, telephone bills, internets, okay, and others, other kind of things like, for example, if you have a clinical, e-clinical system, okay, how much you pay per year, and then you calculate into the days and also the minutes, okay, sewage, the sanitations, or the janitors, you have to put into account, okay. Others is maintenance, how much the building maintenance, okay, for example, if you have to do you have to paint the wall, you need to change the pipe, all the things should be put under the maintenance. The autoclave services, the calibrations, okay. Dental chair definitely have to maintain. If you don't maintain, you don't put into your maintenance. Usually dental chair, the best is once a year. Like you have to do maintenance every year. Okay. The if you after 5 years, after 5 years old, you have to maintain every 6 months. Okay. You have to put into your cost. Okay. Sharp and yellow bin. Okay. Usually, okay. Okay. My advice: do not skip doing this. Okay, because some of my experience working, they don't really care about the infection control. Infection control, the universal infection control, you have to follow. Okay, because you want to how to say. If I've said this is based on our professionalism. Okay, I'm not talking about the other way around. So based on professionalism, you have to follow this kind of things because you don't want to infect others or you want to be infected by others. Okay, all these kind of things you need to involve in your pricing, your costing. Okay, others, okay, if you have OT, if you do OT, for example, like 8 hours is the basic one. If you work until 9 o'clock in the night, so how are you going to are you going to put into your cost? Yes, you have to put in your cost. Okay, or you have locum is the part timers. For example, like you work until from 9 to 6 o'clock. So after 6 to 9 is other people. So you want to hire them to work as a locum. We call it as locum or part timers. So you have to also calculate the price of the money involved in paying the locum. Okay. So that's for the some of the that one is the basics related to the cost for the materials and also the basic one for human resource and also the equipments. Now, okay, this is what I did for my clinics. Okay, so you have all that. Okay, now talking about the materials. So this is all the materials involved when you do amalgam, for example, the composites, okay, GIC, the glass ionomer cements, okay, the dressings, the temporary fillings, pulpotomy, okay, all these things. Okay, if you have others you want to put, you can put inside it. Okay, second visits, pulpotomy, second visits, okay, scaling and polishing, okay. Usually scaling and polishing is the material is not much, okay, the cost is very small, but the most of usually okay, dentists they get more money on this kind of treatment, okay, scaling and polishing, okay. But depends also to the severity of the plaque control. If you have a very severe calculus, usually this kind of patients, I do quadrant by quadrants. First quadrant, second quadrants, third and fourth quadrants, left or right, and then later. So you have to have another visit for this patient. If not, but don't jeopardize your own professionalism. Don't just remove the superficial supragingival calculus alone. Do the best, then become a best dentist, the good dentist when you treat the patients. If patients have supragingival, do supragingival. Don't skip it because you want patients to come and become loyal to your clinics. So treat them better. Don't skip. Don't just talk about money. Treat them, but you have to plan. If you manage wisely, it's okay. For example, like if you just first visit, superficial. But this one is, but don't just do a gross scaling. Mean that you just put some minimal, the left some minimal what call it, calculus. Mean that you want patient to come back and then say, okay, we have removed the heavy one, but there's still something left here, so I need you to come back. So you charge charge them another visits, but there's time you have to go for the supergingival, and then you go if you don't have periodontist, you can refer to the periodontist. If you are the periodontist or you want to become one of the periodontists and you attach to the periodontist, so you can do the periodontal treatments if you want. So all these kind of treatments, okay, diagnosis imaging, okay, the sets, the imaging sets, the basic treatment sets, and involve the envelopes, because envelope meaning that the X-rays, X envelopes, and the wipe. The wipe is if you put patient on the chair, so you might want to consider the one, the infection and the wipe that you wipe using these sanitize the chair. Okay, all this should be included in your costing. Okay, the extractions, so all there. Okay, you can see very detailed. All detail is in there. Okay, this one is for the basic treatments. Now go for, I also put on helping you the costing for specialist treatment. This one because I'm doing this for my specialist clinics. So all this is the costing for specialist clinics. So thank God, thank Allah. Okay, so giving me the opportunity to do this. Okay, so to help others to improve their own costing. Okay, so endodontics for anterior teeth. So all this involved. Okay, you can put into, you can detail up all the things that are inside here. Okay, so how much? Okay, so that's why if you see the specialist treatments is really expensive because of the cost. Also is how much do you think the cost for that? All the cost for that very expensive. Now the price of materials is increasing. What do you think? It might increase, right? Increase, the price will increase. So that's why using this ABC, the costings is really good, helping you to identify the exact cost for the treatment. Okay. Lastly, okay, this is this one is I don't put everything. So you can put, for example, like this materials is based on this kind of costing. Okay. For doctors, okay, the stuffing, okay, I don't put the real one because this one is the old one. The 15 ringgit is the new one that I calculated. It's the old one, 10 ringgit per 30 minutes, per 30 minutes. Okay, this one, the cost is I did for 30 minutes per treatment. So for example, like composite, for example, like here I put as one surface, how much? Two surfaces, how much? More than two surfaces, how much? See, very detailed. So all is detail. See how much that I did, okay, to help you to do all the things, okay. And this one is for this one is okay. This is for my this one is you can skip it. So this is I just want to compare between this one and that one. The other clinics with my clinics with all this. This is the type the price that have been proposed by the associations, dental associations, Malaysian association those days. But now they don't have any limits. You have the minimum, but you don't have limits of that. And then this is for the dentures. Okay, dentures work. Okay, how much that we price our patients. Hopefully it's not out from the United. Okay, I hope so. Okay, inshallah, I pray for it. Not because this is for you to learn and for you to use it. Okay, so I'm go back to my slides. Okay, so you can look into it again. Okay, to look into it detail by detail and detail to item by items, and then you can try it. Okay, maybe you can. What I can do is that during your clinical sessions in the clinics in Unite, you can try. Okay, what are details? So for example, like what I put into my Excel. Oh, Dr. Azlan doesn't put this one. Okay, you put one and then you try calculate. Okay, you can practice it. And actually, if you do it routinely, you actually can use it during when you open your own clinics, or if you work in the other clinics, so you can cost. And then sometimes you propose your own. Don't copy paste. Propose your own. Okay. Even though I learned about it, I don't copy paste my lecturer's one. I put it my own. Okay. Okay. So you can read it and then you can try it. Okay. Now I go back to my slides. Okay. I'm going to share back my slides. Okay, so this is example that can that I take it from my lecturers. Okay, they're giving the formula for each and every single for hospital. So you have, if you build your own hospital, this is all the things that involve in the hospital costing. Okay, we have shared costs. Okay, admission costs, billing cost per patients. Okay, um, the pharmacies, okay, the other like scrub nurse, nursing services, etc. Okay, okay, this is the things that I want to show you. If you buy a building, how you're going to calculate the how do you count the annualizing factors. So usually for hospital, they put it under 5% discount rates. Okay, so for 5 years, okay, the annualization factors is here. Okay, 4.329, and for 10 years with the hospital building, they use the 20 years of factors. So it's around 12.462. So it's this table actually there is a book, okay, talking about it. So you can, I don't know, I don't, because I using it from my lectures, a lecture before this. So she gave us, this is the discount rate. Okay, I think this is come up with WHO. I think you can search it from WHO guidebook. Okay. So I think our question and answer will be later. Okay, I proceed with the clinical pathway. I have another 20 minutes. Okay, what is clinical? Okay, so everybody clear about ABC? If you have any question, you can ask me later after we finish the slides. Clinical pathway is talking about what are the treatment involved, what are the procedures involved when you do a patient. Okay, so it's an optimal sequence and timing of interventions by physicians, nurses, and other disciplines for a particular diagnosis or procedures designed to minimize delays and resource utilization and to maximize the quality of care. Usually, if you look into the practice guideline, okay, I think most of the clinical practice guideline, the CPG, I think most of the government come up with the health care. Okay, in each government they have this CPG, the clinical practice guideline. So usually this clinical practice guideline following the clinical pathway. Okay, so at the end of the work, they want to have this maximized quality of care. For example, they try to minimize the error while treating the patients. Okay, so it's a multidisciplinary plan for best clinical practice. So usually all the experts in the clinics, okay, like orthodontists, periodontists, restorative, prosthodontists, they work with the CPG to come up with detail of each procedures. For example, like in orthodontics, the impacted tools, okay, for restorative, the deep caries management, they all have this procedure, the specific procedures for the clinical pathway. So a clinical pathway is a plan of care drafted in advance for predictable patient groups, which is developed and used by multi teams. Okay, so when they have this like we call it as the joint clinics, okay, they have this kind of because sometimes when you do a treatment, sometimes you involve other departments to help you. So all these documented procedures we put into the CPG, the clinical practice guideline. So every dentist should follow this clinical practice guideline, and all these things will be calculated to the cost. Okay, so they want to minimize the variance between the practitioners. So it is a management and in costing there is clinics using clinical pathway to predict the cost, but usually this one is using in the institutions, the big institutions. Okay, to manage and do this is for tools for management, also the clinic audit. Okay, and began with admission and ended with discharge. For example, like if you in the hospital, when you do these kind of things, you have all the procedures involved from start until you discharge patients. So it's interdisciplinary focus, and it's merging. As I said, it's usually involve the hospital base. Okay, the specialist work. Okay, and why you adopt clinical pathway? Because of the standardization, you don't want to have what do you call it, variance between the practitioners, okay, because you want to become transparent, to show accountability, because you're using the evidence base, meaning that in research base, okay, multidiscipline, quality of care, you want to protect the quality of it, efficiency of the care, and lastly for flexibilities for variance. So you try to avoid this variance. For example, if you are variance, so you have to have calibrated between you, so you're doing the same things, but there might be a a variance in doing the things, but the basic one, the important one, is not being being too much variety. Sorry. Okay, so I'm going to the end of it. Okay, for as a conclusions, ABC course is very tedious and complex matters. Really tedious. Okay, for me, I took around 2 weeks to complete my ABC costing, and then I presented to my boss, and then with that costing, they approve it, and alhamdulillah, they're using the costing for that clinics. But I don't know now. Hopefully, they're still using it. So a day-to-day practice of ABC method will improve the skills. So if you do the daily basis, actually you can actually improve your skills in doing this ABC costing. The methods will help the entrepreneur to get the best or optimal value of patient charges. So if you think that you want to give discounts, so you have all the cost the cost analysis that you did. So for example, like the price actually the cost for that treatment only cost you around in ringgit ratio around 100 ringgit. So you up the price, maybe you price it around 200. So if the patient asks for the discount, so you can say, okay, I'll give you like 20 to 25%. So I just charge you 150 ringgit. So actually you have counted the cost, but you have this 50 ringgits extra for the profits. Okay. So but it depends also if your flow of patients is based on the 30 minutes of charge 30-minute charges, for example, like every single appointment have been booked, so it's okay. But if not, you need to really work that it is suited to your operations. I think that's all. The best of luck for you to do the costing. So I hopefully that some of you maybe later can thank me by using that cost analysis. Okay, back to you, Todini.
Okay, thank you so much, Dr. Azlan, for delightful presentation today. Okay, we also have several questions.
Okay.
Actually, it come from the question that will be sent to me in the in the first session, but I think it's related to this topic in the second session of this topic. Okay, the first question is a very basic question, Dr. Azlan. Maybe
Okay.
the students want to hear about your experience
Okay.
on how to start up the dental clinic or dental practice. And the students highlight actually how to get the startup capital or the capital to start up the dental clinic.
Oh, okay, interesting. I think my wife, she opened her clinic when I was in my postgraduate study. Okay, that's my first experience. Okay, 1 year before my submitting my thesis, she opened her own clinics. So a lot of things happening. Okay, that one I involved a lot of back and forth, register her clinics. Okay, with the Ministry of Health. We have a unit for private healthcare. Okay. For starting up your clinics, okay, there are several things. I might forgot all the things, but the things that I remember, I will tell you. The first thing, if you want to start up cost, okay, the startup capital for there are several ways. I don't know in Indonesia, but in Malaysia, what we did is that for first timer, if you're talking about first timer, I think most of you are the first timer. There are, I think in your country, there are several organizations that can give you some capitals. For example, here we have some organizations like SME Corp. We have the Oryx. Oryx is a company from Japan. Okay, we have some other company that can give you capital to start up your clinics with what do you call it, monthly payment. Okay. And the interest, I don't really like the word interest, but usually in bank they always use this kind of words, interest. The interest is quite okay. Okay, usually in for example, I just sharing in Malaysia. Okay, so you can try translate it in Indonesia. In Malaysia, the interest is around 4% to 5%. Payment per month, I can say the total cost for my our case per month for 5 years is around 5,000 to 8,000 per month. This is based on ringgit Malaysia. Okay, you can okay. So our startup clinic, okay, it depends on your business model. Okay, if your model is the high end, like my wife is high end because they have specialists. We have orthodontists and also oral surgeon in our clinics, in my wife clinics, okay, because data center. So we start up with 300,000 ringgit Malaysian ringgit, okay. Again, sorry, you have. I think you have to translate your place. 300. We have dental X-ray. We have dental X-ray. We have lateral calf and also OPG for orthodontists. Because for me, I don't like to open clinics. Okay, I tell me and my wife. Okay, my wife, they don't want to open clinics just to get profit on it. We want to also put into the risk of patients. For example, like patient come first. We don't want to only looking at our things, more profit on our side, but we want to get best of treatment for the patients. We have this all the things. We have yellow beans, all the infection control is there. We have the daily, weekly yellow bean and sharp bean. People take all these kind of things to dispose it correct way, because usually you cannot throw out what call it, the blood of patients. Simply you have to follow the procedures. Public health, right? I think Dr. Dini also agree with me. You have to have all these procedures. You have to follow all the procedures. So all counted, so 300k. Okay, we buy all the high equipment. Okay, high advanced equipment. We have all this. We have the digital X-ray. So if you are stand alone, you don't do all the data center. You usually, my friends, either around 80,000 to 150,000 ringgit Malaysia. They have a basic one. They have X-ray, the PA X-ray, and you can have it by personal loan or the organization I said you earlier. So this is all the price that you have to pay. But remember, this is all the basic. This 150k is not enough for you for the operation wise. This one is for you to open up your clinics. Operation wise, the salary, the salary, the utilities, all this you have a upfront. So most of the time, usually, if your area is very good area, patient flow is very good. You predict for 1 year or 2 years of break even, so meaning that you can get your own salary, you can pay all your other bills and sell patient your employee 6 months to 1 2 years. So usually like my wife, like my area, 20k is enough. 20k per month is break even. 20k per month is Malaysia lah. You just have to back to you how do you translate it. 20k per month. If you have to have profits, usually after 20, like my wife take around 1 year to get profit around 40k per month to 50k per month. So startup, it's up to your clinics, you data center, advanced treatments or just basic one. But you usually after 2 years or after 5 years, then you can have another capital. You can like my wife, they're expanding. Okay, we have another 4 chairs, 2 already there, and another 2. So we are expanding. So we have another capital around 200k. Okay, for specialists. We have another specialist. We have orthodontists. We have implantologists in our clinics. So all that kind of things should be put into you have to detail up how much, what kind of business you want to operate. Okay, that's all. I think Dr. Dini, so too much detail. Okay, back to you, Dr. Dini.
Maybe the most common problem among the first timer is
Yes.
They may worry to get loan from the bank
Okay.
Because for the first timer, they never know, they can't expect whether the dental practice will give them profits, or maybe they will have loss
Okay.
for
Yes.
starting up the dental practice. So yeah, that's
Okay.
the
My
common.
advice. Okay. My advice. Okay. I know because when we open our clinic, when my wife opened the clinics, also we always put into okay in business. They always I learn it by from my friends, from my economics friends. There will always a risk in your business. Okay, this risk actually the things that Dr. Dini said. Worry is actually a risk. But in business, you don't take that risk. You won't know. You know is your future. How is your future? But planning is very important. I always sign my students. Plan, and plan. If you plan, you have your outcome, what you want to do, what you want to have in next future, and 5 years time, then you work into it. So again, problems, evaluate. Okay, but don't. For example, if you have this kind of money, this is what I have. Okay, work with that money. Don't ever within 5 years to refinance your. This is my advice. Please do not refinance your business within 5 years.
Okay.
Okay, use your own money within 5 years because of my experience is that 1 years actually is very tough years. You
Mm-hmm.
have to spend your own money onto that, but inshallah with the best of luck, I pray for you all. I think all you can become a very good entrepreneur within 1 years. Actually you can get break even and you can go further to your business, but locations and your skills, okay, your soft skills is very important, and management skills. That's all. Dr. Dini, back to you.
Yes. Maybe the most important thing is planning and evaluation
Yes, Dr.
for
Dini.
the
Agree.
cost estimation, because as you say in your conclusion in your first session, you say that if you don't plan your dental practice, you may plan your fail.
Yes.
Okay. Maybe which one do you think is better? We should collaborate with several people to start up the clinic so we can share the capital, or as you say, we can just start up our own clinic and we get loan from the bank. Which one is better?
Uh, it's very tricky. This very tricky question. Okay. Experiencing is based on experience again. Okay. Um, which one is better? I think it depends on your talking about partnerships. It's based people change, right? People change. Maybe today you see me very today you see me very what you call it, happy, right? Happy faces, the way I talk with you, I'm in the good mood. But sometimes the next day when you see me, I'm very in a bad mood. Why would I tell them? Because people always change, because we have these emotions, right? Emotions things. So same thing when you do these partnerships. Okay, sometimes your partner have the same idea with you, but sometimes they don't have. But the good thing of partnership is that Dr. Dini said, that is that the capital can be shared. Okay, the risk also can be shared by others. Okay, by the three. That's why if you want to have a partnership, this my just my 2 cents. Okay, better to have the one with first the one with which have the same visions as you. Okay, if you want to open up a business, they all also have the business minded. Okay, okay, so then go for partnership. But to get to have more money, okay, to get have more money, if you plan to not, for example, yeah, I think I just want to have one clinic only. I don't want to have several clinics. Headache. I don't have that headache. Okay, I want to more family. Then okay, then better to have your own. Okay, maybe or maybe you can have partner, meaning that your partner is your wife or your husband. Okay, okay, married to your clique. Okay, okay, that's the other way. Okay, but I think different business models. For example, if you want to have partnerships, they have their own advantage and disadvantage. Standalone also it have the advantage and disadvantage. Okay, it depends on you. Okay, if you are coming from your family is very supporting, okay, then you can go for standalone. If you like to work 12 hours a day, okay, you don't have enough, you can manage your own time, okay, you can go for standalone, because standalone, okay, as I said, my friends 1.5 is a standalone. Okay, he and his wife, and he can buy a lot of just sharing it, this sharing session. Okay, don't take it as this point, no. Okay, it's just for to sharing sessions, but if it can be right, it can be wrong. my friends is that they husband and wife 1.5 million a month, and now he's driving what I call it Mercedes. I only drive my Toyota. Okay, he's driving his Mercedes after 5 years. Okay, so because for standalone, all money income coming to your clinics is your money. Okay, it's your own money. But if you go for partnerships, you have to divide the dividends in between your partners. So it depends on you. Okay, Tini, back to you.
Yeah. If we want to, if we decide to want to have like a partnership, maybe the contract is the compulsory and it's important.
Yes.
Okay. The next question from our students. The student asks about the difference, not difference. I mean, there's a general dentist and also specialist dentist. And should we differ the salary between general dentist and specialist dentist for their fee for service? Because the skill may be different between the general and the specialist dentist. Should we differ their salary or their fee for service for each service?
Okay. Regarding the salary, okay. If you look into, if you go back to the what do you call it, the training of the dentist, also the specialist. Okay, how much do you spend your means like your money or your scholarship for dentistry for dental graduates to become a dentist? Okay, and then you have to top up another scholarship or another payment, another fees for specialists. So it's different, really different. So yes, you have a different salary for both the dentist and also the specialist training, because to get there to become specialist and also specialists, they know very detailed about, for example, if you become orthodontist, I don't think you learn orthodontist very much in your undergraduates. So if you become orthodontist, the severe treatments, for example, like the class one with very protruded cases, I think the general dentist maybe can do it. But if anything happen, can you manage them? No, the one that can manage that is the specialist. So, for example, like here in Malaysia, we also have considered that kind of thing. For example, because my wife doing the dental center, for the dentist doing minor oral surgery, right? Minor oral surgery, the cost is around for the dentist around 500 and below, 500 ringgit per below and below. But for the specialist is 700 and above. It depends on the difficulties. In my area, the patients doesn't care about who's the price, because they want the best of the treatment. So if the specialist do the case, they say, oh, specialist do it for me. Okay, I'm fine. So sometimes they charge it 1,500 for MOS alone. Patient is okay. So doesn't mean if you charge patient based on the specialties, patient actually it depends. It depends if the patient is if the patient is the high income patients, so that sometimes they don't really care about the price. And also if the patient by insured like they have their own personal insurance for dentistry, so they charge is more than that, and they can do special treatment. So why not? Because specialist is, I think Dr. Dini have to go to Australia. How much they spend for her to Australia? It's a lot. So that also should be count for the pricing. Okay, I think that's all. I think I answering the questions.
Okay, so there's no rule. Maybe like the specialist should receive twice more than the general dentist or something like that. There's no rule, fixed rule.
As I said, you have to look back into the act. Because in Malaysia we have the fee schedule act. In our the price, okay, there are act for it. So usually they have to spend this kind of amount. Okay, so sometimes some area they have this kind of things, or maybe you have to refer to the associations, the dental association for specialists. Okay, sometimes they also have the price, but usually this kind of price is maybe the minimum price. Okay, they don't have, and maybe sometimes when you charge more, you have to remember, you charge more, the risk is high. Okay, you charge. That's why always go back to the guideline. Okay, when you go for guideline, so you save. For when you have a guideline, it's help you to protect you from any charges against you. Okay, and again, these kind of things you have to read again the regulations and the act related to your bodies. Okay, that's all, Dr. Rini.
All right. The next question is still from our student. The student asks about the fee for service or dental charge for people who use dental insurance, because in Indonesia there's dental insurance, national dental health insurance, or also private dental health insurance, but the insurance do not cover all of the dental services. So how can we charge the patient, or should we limit our self service for those patients?
Okay. For regarding the insurance, I think insurance you have to follow their rules. Okay, you cannot breach the rules. Okay, that's my advice, because you don't want, if you break the rules. Okay, you worry that they won't pay you the amount that you charge the patients. Okay, and always believe that if you really sometimes people think about the profit that they get. Okay, but for me, no. Follow rules. Okay, maybe you have some flexibility on it. Okay, but don't charge, don't overcharge. Okay, if you overcharge, usually you can get trouble later. Okay, that's my advice. Follow the rules of the insurance. Don't If you have any query about the charges, you can always call the insurance company. Okay, call them. If I charge this kind of amount, is it possible? They said, is it okay? Ask them about the details. Say, okay, this is this, and then you make a notes again, and then you charge based on that. Okay, but because you do the costing, when you do a costing, you know how much that you can get per treatment. So you can have all the informations regarding the costing and the price. Okay, and you can actually charge that kind of amount. Is it okay, Tony?
Okay, but in some dental insurance in Indonesia,
Mm-hmm.
they cover like dental filling, but only using for particular materials like we say composite. But if the patient wants other materials, the cost is higher than the composite. It will not be covered by the insurance. So as a dentist, we should charge the difference cost
Yeah,
between
yeah,
composite and that material that the patient prefer, or we just stick to say that to the patient that we just give the
okay.
composite for dental filling.
My advice is that that's come the soft skills, the communication skills. Okay, usually patients, you have to educate patients. Okay, you tell them that the treatment that they covered for the insurance is that this kind of feelings, this kind of treatments. Because usually when you talk them very politely, very professionally. Okay, you put all the what do you call it, that's why when you first doing the examinations, you put everything, all the planning, the treatment plan, on the paper, so that patients can see. Talk with them. Okay, what are the treatments that are available? What are the alternatives, etc. And then what are the charges, etc. Okay, I think this one you learn during your undergrads with your supervisors, with your lecturers. When you That's why I said you have the consultations is not only doing the examinations. Talking with the treatment plan also is the consultations. Putting on the consultation price should be included all these things. Okay, the first visits, after you have done everything, tell the patients, okay, this is what you need to do. Okay, if patient want something else, say that, okay, this is not covered in the insurance, I'm really sorry. If you want, you have to go, you have to pay more for the treatments. Patient doesn't want that. I'm really sorry, I can refer you to other clinics that can help you with this. Being polite actually is the best way, saying that patient can come back to you. Actually, what we because I'm a public health, we do a lot of preventive work. Experience in my clinic is that when we actually educate this patient that, wow, why not? Why other clinic doesn't tell us about it? Okay, why this kind of that moment that you tell patients about that, educate patients about this kind of things. Actually, patients really how to say, appreciates your effort to telling them the things, and then patients will come back. But it depends again on the, I don't know, because I think patient in Indonesia and patient in Malaysia is different, but in some way there is similarities. But again, become a professional, you have to become ethical and professional. Okay, telling them, educate them. Okay, that's why I always emphasize to my students, learning dental public health is not about, it's not a waste. Actually, the communication skills, the management skills is really important, because all all you jumble up when you open your own clinics and when you manage your own clinics, when you manage your own patients. I think that's all, Dr. Nini.
Okay. Maybe for the last 2 minutes, the last question is also from our student. The student asks, in Dr. Adlan presentations, the example of cost estimation is likely for if the dentist work in the area or in a city that has an adequate facilities. How if we have to start up our dental clinic in area or in a city that have less adequate or inadequate facilities?
Okay. I not sure. Can you like for example give me what type of inadequate facilities?
Like if we have to
Example.
start up in a remote area,
Okay.
or yeah, the infrastructure is not well developed or something like that.
Okay. My advice. Okay. Okay. This is actually the price, the actual price that you going to do the costings for the treatment. Okay. If you go for remote area, usually if you go for remote area, you can have this kind of, because in Malaysia we have a lot of organization that doing this kind of donation. Okay, donations. There are for example, if you have there are, for example, like we have experience like asking money from the company that have the CSR, the community community doing back giving back to the community. They actually all the company they have some kind of what to say they put aside some amount of money to help the poor. Okay, you can ask from this company. Okay, I don't know in Indonesia, but usually if you because when company one of the way for them to not say run for the tax to reduce their taxes. Okay, they have to they have something that call off the CSR. If you do CSR, they can cut their taxes. Okay, so if you go to company saying to them, okay, I have an idea of doing this kind of area, can you actually give me like more the capital to help this thing? I'm going to do a charity work, charity plus and plus financial work. In Islam, they have call it as a wakaf. That one of the things that we do in our practice, we call it as a wakaf. The company give us some money and also some call it capital as a business things, business management. So we managed to open it in the rural area, and we always also can help poor for free treatment. Okay, so these kind of things, what you can do is do this kind of things, because for me to reduce the price is really not it's impossible unless you try to search for the local, which is very cheap one, but not lasting. Okay, I know that there are some place some company that sell something which is very cheap, like something from Korea, from other areas which is very cheap, but actually what we do is want to have a good treatment for patients, not only profitable kind of things. Again, if you want to go to a rural, there are a lot of company that can give you capital, but you have to work for it. For the first timers, my advice, I don't know. I know it's my advice is okay or not. Do can I say that? Okay, advising something that don't go to rural but working in the city. Is it okay? I don't think so, right? Okay. First clinics. Okay, I think based on my experience, first clinic you have to you have to locate your clinics in the profitable area. Okay, maybe after 5 years, 10 years, you can have your own charity clinics. You might open your clinics, because my friends, I talk about my friends. He has his moving dental clinics. He have own clinics, so they have profit clinics, and every week he will come up with his moving clinics to all the rural area to treat patients free of charge. Okay, that's my advice. Thank you very much.
Okay, thank you, Dr. Aslan. I think we already run out of time, and that will be our last question for Dr. Aslan. So this is the end of our second session in today's webinar, and also will be the last session with Dr. Aslan too. Thank you, Dr. Aslan. It's very interesting to hear about your lecture, and thank you so much for your for sharing your knowledge with us. Please feel free to stay and join with us in our third session of our today's webinar if you don't have any other appointment. But if you do have any other schedule, that should be fine too. Okay, for all participants, this is the end of my task as a moderator for the first and second session with Dr. Adlan. I will pass the task or this webinar to Dr. Gea as the host and also the moderator for the third session. Thank you.
Thank you, Dr. Azlan.
Welcome.
Hopefully, next year will be better and we can meet each other.
Yeah, me too.
Thank you, Dr.
Hopefully.
Azlan. Before sorry. Before ending this lecture, take the photo first.
Oh, okay.
Mungkin bisa dinyalakan ya untuk teman-teman videonya. Saya ambil gambar dulu ya. Oke, saya hitung ya. 1, 2, 3. Oke, sebentar. Oke ya, 1, 2, 3. Oke, 1, 2, 3. Sebentar ya. Oke, 1, 2, 3. Lagi yang kelima. 1, 2, 3. Oke.
So I think I need to go now. I have another work to do after ini, to Taufan. So I think
Thank you, Dr. Azlan.
Ya, thank you, Dr. Azlan.
Thank you, Dr. Azlan. Thank you, Dr. Azlan.
Thank you, Dr. Azlan. Nice to meet you.
And in the near future. Okay.
Okay, thank you.
Yes. Assalamualaikum.
Okay.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Baik, terima kasih dari PH, Dr. Dini, Dr. Taufan, Dr. Gea. Mungkin sesi yang ketiga ini Dr. Erwin ya?
Ya betul,
Dr.
Dr.
Erwin,
Arwin.
saya lihat sudah gabung. Saya ucapkan selamat bergabung, Dr. Erwin.
Nah, terima kasih undangannya. Bisa
Oke,
gabung.
Dr. Nuwun.
Stovit.
Untuk kesempatan pagi hari ini, di sesi yang ketiga ini, Dr. Erwin akan menyampaikan tentang manajemen HIV/AIDS, back to basic. Moderatornya Dr. Ayu ya?
Dari pemandunya saya dokter, kemudian nanti dari moderatornya Dr. Desi. Iya, boleh
ya?
dilanjutkan dok ke. Ya, halo. Pemandu acaranya dari saya dokter. Halo.
Ya, putus-putus Dr. Ayu.
Oh, sebentar dokter. Seperti ini apa udah jelas?
Jelas.
Iya, pemandu acaranya dari saya dokter. Nanti moderatornya dengan Dr. Desiana.
Baik. Saya serahkan waktunya buat teman-teman IPM untuk sesi ketiga SOS pada pagi hari ini. Silakan Dr. Ayu.
Terima kasih banyak Dr. Anis. Jadi kita sampai pada sesi ketiga. Pada sesi ketiga ini akan ada materi dari pembicara kita, yaitu Dr. Erwin Asta Triyono, SPPD KPTI Finasim. Beliau akan membawakan topik berjudul Management of HIV/AIDS Back to Basic. Jadi dengan partisipan dari berbagai strata dari adik-adik mahasiswa S1, nanti saya mengingatkan sedikit. Jangan lupa untuk membuat resume webinar kali ini ya sebagai tugas mandiri Anda semua, dan nanti upload lewat aula. Kemudian pada sesi kali ini akan dipandu dengan moderator dari Departemen IPM juga, yaitu Dr. Desiana Raditya, Dr. Gigi SPPM Konsultan. Untuk mempersingkat waktu, saya persilahkan moderator untuk memandu acara lebih lanjut. Silahkan Dr. Desi.
Oke, terima kasih Dr. Ayu. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi semuanya. Masih semangat ya sesi ketiga. Nah, selamat datang Dr. Erwin. Terima kasih atas kesediaannya untuk memenuhi undangan kami untuk memberikan kuliah gitu ya kepada adik-adik ini, adik-adik calon dokter gigi dan juga calon dokter gigi spesialis dari berbagai bidang ilmu gitu ya. Di sini Dr. Erwin pagi ini akan membawakan topik mengenai Management of HIV/AIDS Back to Basics. Saya mohon dari IT untuk membantu untuk share screen ya, untuk kurikulum vitae dari Dr. Erwin yang akan saya sampaikan. Jadi mungkin sebagai pengantar dia, gegar pandemi COVID-19 ini mungkin membuat sejenak kita lupa gitu bahwa penyakit yang ini, HIV/AIDS ini sudah duluan menyandang gelar sebagai pandemi sebenarnya. Pasiennya masih ada, masih terus bertambah gitu ya. Tapi kita sejenak teralihkan gitu kan karena COVID-19 ini benar-benar memang menjadi satu pandemi yang blasting gitu. Nah, tapi kita harus ingat juga bahwa di negara berkembang seperti Indonesia ini, di mana yaitu tadi pasien HIV-nya masih nambah terus gitu ya. Terus obat antiretroviralnya juga masih belum saja bisa terdistribusi merata. Nah, jadinya penyakit ini nih belum bisa sepenuhnya dikontrol di negara kita. Nah, jadi sebagai dokter gigi, kenapa kok harus back to basics gitu ya? Buat kita, para dokter gigi, kita perlu betul memahami dasar-dasar alami dari penyakit ini, ya. Karena kita nanti harus kita harus tahu pertimbangan-pertimbangan apa yang harus diperhatikan sebelum kita bisa memberikan perawatan dental yang tepat untuk orang dengan HIV/AIDS atau ODA, gitu ya. Nah, jadi untuk tidak memperpanjang waktu, tolong CV-nya bisa ditayangkan. Ya. Pembicara kita pada kali ini adalah Dr. Erwin Astatriono, spesialis penyakit dalam, konsultan penyakit tropik infeksi, Fellow of Indonesian Society of Internal Medicine. Beliau lulus dokter pada tahun 1995 dan 10 tahun kemudian menyandang gelar spesialis penyakit dalam. Tahun 2011 mendapatkan gelar konsultan di bidang penyakit tropik infeksi, dan tahun 2016 mendapat gelar doktor. Ini beliau seperti saya ini, galur murni Universitas Airlangga gitu ya, full UNER. Dan untuk kredibilitas beliau tidak bisa digoyahkan apapun ya. Beliau ini adalah koordinator program studi untuk SP2 subspesialis dari spesialis penyakit dalam. Kemudian ketua tim medik untuk HIV/AIDS di FKUA Dr. Sutomo. Kemudian yang paling top ini sekarang ini, saat ini beliau menjadi kepala rumah sakit lapangan COVID-19 Indrapura Provinsi Jawa Timur. Ya, jadi benar-benar pembicara kali ini insya Allah bisa menjadi yang menjawab semua pertanyaan kita untuk hal yang memang menjadi topik utama pada pembahasan pagi ini. Kami persilakan Dr. Erwin untuk menyampaikan materinya. 1 jam waktunya dok, semoga cukup. Kalau memang masih kurang nanti saya minta pada pemandu acara untuk mengextend waktunya karena kita pengen belajar banyak dari Dr. Erwin hari ini. Monggo Dr. Erwin, silakan.
Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Yang salam sejahtera untuk kita semua. Yang saya hormati Dr. Desi yang telah berjuang untuk memperkenalkan saya. Terima kasih. Yang kedua, Bu Nurina, Bu Anis yang tadi sudah sempat kita lihat kontribusi untuk kegiatan ini. Yang jelas hari ini saya bangga sekali dan senang sekali diundang untuk Stovit online series ya, di mana isu HIV nanti moga-moga bisa mewarnai kompetensi dari teman-teman, baik itu profesi dokter gigi maupun profesi dokter gigi spesialis. Yang mana untuk HIV sendiri tidak bisa lepas dari kegiatan kita sehari-hari, semua kompetensi sangat mungkin terkait dengan HIV. Sehingga betul sekali Dr. Desi, memang tinggal dua pilihannya, HIV yang mendekati kita atau kita yang mendekati HIV. Artinya gini, kalau kita nggak mau mempelajari HIV, maka suatu saat HIV akan mendekati kita dengan cara yang kita nggak tahu. Sehingga hari ini tugas saya lebih banyak untuk memberikan penekanan gimana cara memahami dengan benar, sehingga nanti, mohon maaf, jangan sampai panik dengan HIV, tapi jangan sampai lengah dengan HIV juga. Jadi hampir semua penyakit-penyakit yang terkait pandemi seperti HIV, COVID itu memberikan memaksa kita untuk memahami secara utuh. Oke, saya akan lanjutkan slide. Bentar. Ini data yang ada di Indonesia sampai tahun ini. Ya. Kurang lebih estimasinya 543.100 ODA pada tahun 2020. Estimasi. Ya. Apakah jumlah ini menjadi jumlah optimal? Belum tahu. Kenapa? Dengan era COVID ini, isu HIV agak sedikit dilupakan. Jadi sekarang yang jadi booming adalah semua membahas tentang isu COVID. Padahal isu HIV sendiri merupakan bagian dari penyakit lain yang mungkin juga perlu mendapat perhatian. Di samping penyakit-penyakit lain yang terkait dengan metabolic syndrome, stroke, hipertensi, gagal ginjal, gagal jantung, dan sebagainya. Sehingga kalau lihat isu yang sekarang ada di media-media, rupanya orang lebih takut COVID dibanding meninggal karena penyakit jantung misalkan. Nah, itu sangat tidak proporsional sebetulnya. Sehingga hari ini kita akan coba mensinkronkan antara isu COVID dengan isu HIV. Ini para mahasiswa semuanya termasuk staf. Pada prinsipnya Permenkes terkait dengan penanggulangan HIV/AIDS itu cukup lengkap ya. Kita punya target 3-0 pada tahun 2030. Zero yang pertama adalah zero HIV infection. Jadi mau nggak mau tugas kita sama-sama, baik itu dokter gigi, perawat, dan sebagainya, itu punya kontribusi untuk gimana upaya menemukan kasusnya. Ya. Dan setelah ketemu, maka segera diterapi sehingga jangan sampai nanti ada infeksi-infeksi HIV yang baru. Yang kedua adalah zero kematian. Jadi mau nggak mau, strategi terbaik kita adalah ayo cepat temukan. Dengan begitu kita bisa memberikan tata laksana lebih awal. Jangan sampai ketemu stadium lanjut yang membuat angka kematiannya menjadi tinggi. Dan itu sangat terkait sekali sekarang dengan problem COVID. Ya. Dan yang terakhir adalah zero discrimination. Sehingga jangan sampai nanti teman-teman dokter gigi begitu ada pasien yang ngaku HIV kemudian tidak memberikan layanan terbaik. Padahal sebetulnya kita tetap punya tata cara yang excellent untuk membuat kita bisa merawat pasien HIV dan melindungi diri kita jangan sampai tertular dengan HIV. Sehingga hasil akhirnya yang paling bawah, jadi prinsipnya temukan kasus sehingga 90% orang yang punya resiko harus diketahui statusnya, 90%. Setelah itu 90% berikutnya adalah dari 90 yang ditemukan tadi, diharapkan 90% akan segera tertangani dengan pemberian pengobatan. Setelah itu target 3-0 yang ketiga adalah 90% yang diobati itu diharapkan dalam 6 bulan virusnya sudah tidak terdeteksi. Nah, isu seperti ini kadang-kadang perlu disampaikan pada setting-setting kuliah seperti ini supaya nanti pemahaman kita sama. Jangan sampai yang ada di dalam pemahaman kita hanya sebatas HIV itu menakutkan, mengerikan, nggak ada obatnya, tanda tangan mati. Padahal isu yang sekarang beredar adalah secara ilmiah bahwa penyakit ini sebetulnya bisa dicegah, bisa diobati. Itu menjadi isu yang pertama yang perlu mendapat penekanan. Dan ini target awal sebelum mencapai target 2030 ya. Untuk yang target awal 2024 ini mungkin kita nggak perlu sampai 9 tetap untuk penemuan kasusnya 90% harus tahu statusnya, harus ditemukan. Tapi untuk pemberian ARV kadang-kadang tadi udah disampaikan Dr. Desi, nggak semuanya bisa langsung mendapatkan ARV. Ya oke lah, target transisi kita 60%. Tapi 2030 90% harus mendapatkan ARV. Kemudian untuk target antara ini yang tersupresi itu sekitar 60%, meskipun tahun 2030 diharapkan 90% bisa tersupresi. Pada prinsipnya negara ini sudah siap dengan sistem yang ada. Tapi tetap aja banyak plus minus dari sistem yang sekarang kita udah punya. Anggap aja dengan era pandemi COVID ini, hampir sebagian besar sistem yang sudah kita bangun ini seakan-akan lumpuh untuk tata laksana pemberian atau tata laksana terkait dengan manajemen HIV. Ya. Sehingga kadang-kadang terlupakan dan penemuan kasus, tata laksana sedikit banyak akan mempengaruhi kualitas layanan terhadap pasien-pasien HIV. Satu isu yang sampai sekarang masih tetap kita perlu tekankan yaitu fenomena iceberg. Jadi fenomena gunung es ya. Di mana upaya kita yang sekarang ini kita lakukan adalah tetap gimana cara mengeluarkan bongkahan gunung es yang ada di bawah permukaan air ini supaya terdeteksi semuanya. Ya. Sama dengan fenomena COVID ini, gimana upaya menemukan kasus sehingga antara testing, kemudian tracing, testing, pengobatan itu menjadi satu kesatuan yang harus dikerjakan. Jadi pintu utama dari teman-teman spesialis dokter gigi maupun dokter gigi dengan profesi dokter gigi itu diharapkan membantu program pemerintah ini. Melalui apa? Melalui salah satu petanda-petanda yang mungkin bisa dikaitkan dengan HIV. Contohnya, bila teman-teman dokter gigi pada saat memberikan layanan gigi, kemudian menemukan di situ ada kandidiasis misalkan, itu sudah bisa untuk membantu kita gimana cara untuk mengajak pasien supaya mau pemeriksaan untuk HIV. Itu salah satu petanda terkait dengan penyakit HIV. Para sejawat semuanya, ini merupakan clinical course dari pasien HIV yang tidak diobati. Yang bisa kita lihat di sini adalah nomor 1, begitu tertular HIV, ada yang namanya infeksi HIV primer. Kemudian dia lanjut kepada sindrom HIV akut. Ini relatif susah ditemukan. Kenapa? Karena gejalanya mirip dengan penyakit yang lain, misalkan flu-like syndrome, yang mungkin ada batuknya, ada pileknya, ada demamnya. Itu HIV. Ya. Kemudian setelah itu fase di mana imunitas tubuh berhasil untuk menekan sementara infeksi HIV, sehingga gejalanya cenderung asimptomatik. Dan ini berlangsung bertahun-tahun. Setelah suatu saat antibodinya kalah, maka virusnya akan meningkat dan infeksi tumpangan itu akan memberikan kontribusi gejala atau simptom dari HIV. Sehingga kalau kita ditanya, apakah gejala penyakit HIV itu, pada prinsipnya HIV nggak punya gejala. Karena HIV pada prinsipnya tugasnya hanya menurunkan kekebalan kita. Tentara kita dihabisi oleh infeksi HIV ini. Setelah infeksi HIV ini cukup membuat daya tahan kita habis, maka infeksi tumpangan itu yang memberikan kontribusi gejala. Artinya, kalau HIV kemudian diikuti penyakit TBC, maka gejala yang tampak adalah TBC. Kalau HIV kemudian ditumpangi oleh penyakit infeksi oportunistik toksoplasma, kemudian sitomegalovirus, jamur, maka gejalanya akan mengikuti gejala dari penyakit-penyakit tumpangan tadi. Sehingga hati-hati pada pasien-pasien yang awal infeksi biasanya tidak menimbulkan gejala, tapi dia sudah bisa untuk menularkan HIV kepada yang lain. Ya. Tapi tentunya cara penularannya berbeda dengan COVID. Kalau COVID, batuk, pilek, bicara, pegang, dan sebagainya udah bisa nularkan. Sedangkan untuk kasus-kasus sisa HIV, hanya 2 yang paling mungkin, yaitu hubungan seksual beresiko dan narkoba suntik. Ya. Kemudian kita lihat gimana cara pemeriksaannya. Kita lihat di sini bahwa 0 sampai 2 minggu ini masih awal sekali. Kita belum bisa deteksi. Ya. Dan ini pintu terbaik untuk penularan melalui transfusi darah. Jadi pada pasien-pasien yang masih 1 minggu atau 2 minggu tertular, kalau misalkan nanti masuk PMI kemudian transfusi, relatif memungkinkan regen yang ada di PMI tidak bisa mendeteksi ya untuk keberadaan HIV. Tapi kasusnya sangat-sangat jarang. Kemudian kalau mau memeriksa maka kita bisa menggunakan PCR. Ya, jadi setelah 2 minggu memang antibodi belum muncul sehingga yang bisa kita lakukan untuk memastikan pasien-pasien apakah tertular apa tidak menggunakan PCR. ELISA atau antibodi baru muncul setelah 4 minggu. Jadi kita baru bisa menggunakan regen serologi untuk pemeriksaan HIV setelah lebih dari 4 bulan infeksi. Ya. Ini hal-hal yang mungkin bisa kita kaitkan nanti antara gejalanya, kemudian timbulnya antibodi sampai apa yang harus kita lakukan pada saat ingin memastikan apakah pasien kita terinfeksi HIV atau tidak. Ini progresi HIV untuk menuju AIDS. Ya. Jadi pada prinsipnya gambarnya mungkin akan kita, nah ini yang lebih jelas. Jadi pada fase akut, antibodinya akan turun sebentar. Setelah itu antibodi ini, mohon maaf, CD4 ini akan naik. Begitu antibodi atau CD4 naik, maka infeksi virus sebetulnya secara alamiah akan ditekan oleh antibodi kita. Ya. Meskipun setelah 1 tahun, 2 tahun, 3 tahun, 4 tahun, 5 tahun, kekebalan kita udah mulai kalah. Dan virusnya sudah mulai naik. Begitu kekebalan kita kalah, maka infeksi tumpangan akan siap untuk masuk. Ini yang sebetulnya kita harus waspadai. Karena kembali pada statement awal, bahwa HIV itu, mohon maaf, tidak akan membunuh, tidak akan bikin gejala penyakit, tapi tugasnya hanya menurunkan kekebalan. Setelah kekebalan kita habis, maka infeksi lain ini yang akan memberikan kontribusi gejala. Tadi udah kita sampaikan kalau TBC masuk maka gejalanya ikut gejala TBC. Herpes zoster, oral hydroxyplakia, kemudian kandidiasis. Ini pintu-pintu terbaik pada saat kita memeriksa rongga mulut dari pasien-pasien HIV yang sudah stadium lanjut. Ini ada 3 kelompok ya. Sehingga kadang-kadang di masyarakat atau pasien-pasien kita, seringkali ada kelompok yang mohon maaf, dalam hitungan kurang dari 3 tahun sudah masuk kategori AIDS, meninggal. Berarti infeksinya masuk kelompok rapid progressor. Kemudian ada yang ya butuh 7-12 tahun, itu berarti perjalanan alamnya seperti itu. Ada yang sampai panjang sekali. Jadi meskipun dia sudah lama sakit, tapi relatif untuk menuju kondisi stadium 3 atau 4 itu butuh waktu sekitar 10-15 tahun. Tapi sekarang kita udah ubah pemahaman ini, sehingga kita nggak peduli apakah itu termasuk typical progressor atau rapid atau long term, semuanya begitu diketahui terinfeksi HIV maka segera mendapatkan ARV. Kuncinya pada kecepatan untuk buat diagnosis awal dan segera memberikan tata laksana. Kenapa 10-15 tahun yang lalu stigma HIV itu begitu kuat, yang dianggap waktu itu betul-betul penyakit yang mematikan. Karena pada saat itu stigmanya masih cukup dominan. Ya. Dengan stigma yang dominan, maka pasien-pasien dengan HIV saat itu tidak tertarik untuk ditemukan. Ya. Dengan tidak ditemukan, maka ditambah dengan stigma, dibuang oleh keluarganya, membuat imunitasnya turun karena nutrisi dan stres itu juga memberikan kontribusi penurunan dari imunitas. Sehingga pada saat itu mudah sekali pasien-pasien HIV begitu ketemu dalam hitungan beberapa hari minggu ke depan kemudian meninggal. Ya. Dan ini sekarang udah kita rubah strateginya menjadi penemuan kasus lebih awal dan terapi yang jauh lebih dimudahkan. Ini sekarang kita akan berikan informasi terkait dengan HIV. Tadi sudah kita sampaikan bahwa HIV adalah virus yang menurunkan kekebalan. Artinya tugasnya dia adalah menurunkan kekebalan. Kalau ditemukan cepat maka nggak sampai drop kekebalannya. Tapi kalau tidak cepat ditemukan maka begitu sudah stadium lanjut, maka siap-siap infeksi yang lain, infeksi oportunistik yang kita namakan infeksi tumpangan itu bisa satu persatu akan masuk. Jadi tugasnya sel HIV itu ya menghabisi tentara kita, limfosit T. Sebetulnya yang diserang HIV itu bukan hanya limfosit, tapi pada prinsipnya adalah semua sel yang punya petanda CD4. Sialnya CD4 itu lebih banyak terdapat pada limfosit sehingga betul-betul lumpuh kekebalan yang dimasuki oleh virus HIV. Apa bedanya HIV dengan AIDS? Kalau satu virus masuk, dinamakan infeksi HIV. Kalau nggak cepat ditemukan, maka pelan-pelan tentara kita akan habis. Kalau tentara kita habis, maka TBC masuk. HIV dengan TBC itu yang kita namakan AIDS. HIV dengan candidiasis oris itu yang kita namakan AIDS. Artinya apa? Nah, kalau pemahaman kita udah seperti tadi, berarti HIV dengan TBC adalah AIDS, maka tidak perlu ada pemahaman bahwa AIDS itu tanda tangan mati misalkan. Kenapa? Karena kalau kita obati TBC-nya, maka dia akan bergeser kembali menjadi infeksi HIV biasa. Begitu kita berikan ARV, maka dia akan jadi orang normal lagi dari sisi imunitas. Sehingga filosofi terbaru yang kita dorong untuk pemahaman pada semua mahasiswa atau tenaga medis adalah nggak usah buru-buru memvonis bahwa orang dengan stadium lanjut atau AIDS itu layak mati, enggak. Karena begitu kita upayakan untuk mencari infeksi oportunistiknya, maka diharapkan kita bisa mengembalikan posisi imunitas menjadi sama seperti orang normal lagi. Ini stadium klinis yang disampaikan oleh WHO. Ya. Kita punya stadium 1, 2, 3, 4. Stadium AIDS itu adalah stadium 3 dan 4. Ya. Sedangkan stadium itu dinamakan stadium asimptomatik atau simptomatik tapi masih aktivitas normal. Ketika kita ditanya HIV gejalanya apa? Maka pada prinsipnya HIV itu nggak punya gejala, dia akan mengikuti infeksi tumpangannya. Buktinya apa? Stadium 1, relatif hampir nggak ada gejala. Kecuali pembesaran kelenjar getah bening. Ya. Tapi jarang sekali para dokter yang rutin memeriksa untuk pembesaran kelenjar getah beningnya. Yang kedua, berat badan udah mulai turun. Kemudian ada infeksi pada mukokuntaneus, misalkan di bibir ada luka-luka karena jamur, karena parasit, kemudian herpes, itu juga boleh mulai dicurigai. Tapi tidak semuanya langsung dikaitkan dengan HIV. Biasanya manifestasi mukokuntaneus itu berulang. Jadi sekarang ada, nanti 6 bulan lagi ada lagi, nggak hilang-hilang, itu baru kita mungkin bisa kaitkan dengan penyakit-penyakit HIV. Tapi kalau kayak herpes zoster yang teorinya itu seumur hidup sekali, Kalau dia hanya sekali berarti nggak perlu buru-buru dikaitkan dengan HIV. Tapi kalau berulang setahun kemudian, 2 tahun kemudian herpes lagi, itu baru kita mungkin kaitkan dengan HIV. Stadium 3 harusnya lebih mudah lagi. Karena gejala-gejala diare kronis, demam kronis, kandidiasis, kemudian OHL, itu sudah boleh kita arahkan kemungkinan HIV. Cuma seringkali pemahaman ini nggak tersampaikan ke tenaga medis sehingga dianggap itu jamur-jamur biasa, padahal itu bisa dikaitkan dengan problem HIV. Kita lihat stadium 4. Hampir semua infeksi ada. Ya. Baik itu di rongga mulut, manifestasinya atau di kepala, di mata, semuanya mungkin. Tapi isu yang kita bangun adalah bukan berarti stadium 4 itu layak meninggal, tidak. Karena 1-16 ini prinsipnya bisa diobati. Tugas kita hanya berusaha untuk mencari infeksi oportunistik apa yang ada. Yang susah hanya nomor 14 dan 15 ini, karena termasuk keganasan. Tapi sisanya di layanan-layanan yang kita sekarang punya, misalkan BPJS, obat-obat ini semua sudah kita masukkan dalam formularium nasional. Ini kita lihat infeksi oportunistik yang umum terjadi. Bisa di mata, bisa di otak, bisa di mulut, bisa di paru, bisa di usus. Artinya apa? Kalau daya tahannya sudah lemah, karena nggak cepat ditemukan, maka hampir semua organ bisa dimasuki oleh kuman-kuman yang kebetulan Indonesia itu area yang dikaitkan dengan area tropis, sehingga semua kuman relatif mudah tumbuh di Indonesia. Sehingga salah satu kerugian orang HIV di Indonesia adalah dia akan mudah sekali atau rentan sekali untuk kemasukan infeksi-infeksi tambahan, baik itu dari kelompok bakteri, virus, parasit, dan sebagainya. Sedangkan untuk infeksi oportunistik nggak ada pilihan kecuali tadi udah kita sampaikan, sesegera mungkin untuk ditemukan dan sesegera mungkin untuk mendapatkan ARV-nya. Dan pencegahan jauh lebih baik, misalkan kita mesti minta bantuan teman-teman dari kompetensi dokter gigi untuk membantu gimana higiene mulut yang bagus supaya jamur tidak mudah tumbuh. Kalau ada pertanyaan, virus HIV ada di mana? Prinsipnya 2. Di cairan darah dan organ seksual kita. Ya. Organ seksual. ASI ini relatif sudah mulai tidak terlalu diperhatikan, ya. Dengan program PPIA, pencegahan penularan ibu ke bayi dan pemberian ARV pada ibu, maka ASI tidak menjadi penular yang baik, ya. Sangat kecil kemungkinan tertular lewat ASI. Yang paling penting 2 ini, yaitu penggunaan narkoba suntik dari darah dan hubungan seks yang beresiko. Gimana kita dapat terinfeksi HIV? Pada prinsipnya kalau dibandingkan dengan COVID, mohon maaf, jauh lebih mudah nular COVID dibanding HIV. Kita lihat, untuk menularkan ada 4 tahap yang harus dilalui. Nomor 1, virusnya harus keluar dari tubuh manusia yang terinfeksi tadi itu. Jumlahnya harus cukup, HIV-nya harus hidup, dan ada pintu masuk untuk menuju ke manusia berikutnya. Jadi tidak akan semudah itu. Contoh, misalkan di jalan ada kecelakaan, kita bantu korban itu, tangan kita penuh dengan darah, kemudian ternyata itu pasien HIV, apakah pasti tertular? Jawabannya tidak. Karena apa? Nomor 1, tercukupi. Memang ada darah yang keluar dari tubuhnya. Ada virus yang hidup, ada jumlah yang cukup. Tapi belum ada pintu masuk ke dalam tubuh penolong tadi, maka bisa kita katakan bahwa tidak mungkin menularkan pada orang berikutnya. Jadi relatif susah. hanya dua yang paling mungkin, yaitu hubungan seksual beresiko dan narkoba. Karena dengan narkoba itu kita dibuatkan akses untuk masuk ke dalam tubuh orang berikutnya. Ini tadi yang kita sampaikan, hanya dua yang paling mungkin, hubungan seks sama narkoba suntik. Sedangkan untuk ibu ke bayi, dengan program pemerintah pencegahan dari ibu ke bayi, diharapkan sudah sangat-sangat menurun kemungkinannya. Dan lewat transfusi darah sudah sangat menurun karena kita punya regen terbaik yang mampu mendeteksi HIV pada orang donor yang setelah 1 minggu tertular. Jadi tetap masih ada peluang meskipun sangat kecil, antara 0 sampai 7 hari pasien yang barusan tertular, setelah itu melakukan donor darah itu memang bisa lepas, tapi resikonya sangat-sangat kecil. Ini tadi sudah kita sampaikan, pada prinsipnya penggunaan narkoba suntik ini yang paling penting. Kenapa? Karena untuk alat-alat medis sekarang sudah disposable, nggak mungkin atau nggak bisa menggunakan yang reuse atau non-disposable. Kemudian hubungan seksual tanpa kondom, ya, ini memberikan kontribusi penularan, ya, sehingga dua hal tadi yang perlu sangat diperhatikan terkait dengan proses penularannya. Ini silahkan dibaca, tapi pada prinsipnya yang diingat cuma dua. Selama tidak melakukan hubungan seks dan narkoba suntik, nggak mungkin tertular. Sehingga yang namanya ciuman, pelukan, kemudian kamar mandi, sentuhan, alat makan, nyamuk, tinggal serumah, tidak menularkan. Jauh lebih sederhana penularannya relatif daripada COVID yang sekarang kita lagi fokuskan. Ini dua hal, tetap heteroseksual dan pengguna narkoba suntik. Kemudian setelah kita memahami definisi, kemudian cara penularan, terus kemudian proses patogenesis dari HIV, sekarang gimana dengan pengobatannya? Pada prinsipnya, satu, kita punya namanya ARV. ARV ini tugasnya satu, saya nggak tertarik kalau ada yang menyampaikan bahwa ini untuk memperpanjang hidup, tidak. Ini betul-betul bisa untuk membunuh virusnya. Sehingga dalam 6 bulan diharapkan virusnya sudah tidak terdeteksi. Di situ saya tidak bilang 0, tapi memang alat tidak mampu untuk mendeteksi kalau itu jumlah virusnya sangat-sangat minimalis. Kemudian yang kedua, ini penting untuk para dokter gigi atau spesialis, bahwa kalau misalkan ada yang pernah beresiko, artinya memasang infus atau melakukan injeksi, tertusuk, maka kita punya yang namanya profilaksis pasca pajanan. Jadi teman-teman yang merasa beresiko tadi cepat lapor supaya kita bisa memberikan ARV profilaksis. Ini penting untuk tenaga medis. Kemudian yang berikutnya bisa mencegah dari ibu ke bayinya. Ini tantangan kita ke depan. Ya. Gimana pun HIV itu tetap berproses, cuma mungkin sudah melewati fase-fase kepanikan, nggak seperti yang COVID sekarang masih setting-setting panik yang kita karena belum tahu persis tabiat dari virus COVID. Nah, HIV relatif kita udah memahami tabiat dari virus ini sehingga ke depan tinggal mengembangkan, terutama dari tata cara pemeriksaan CD4, mengembangkan obat-obat baru, kemudian keuntungan ARV yang bersifat individual atau populasi, kemudian nanti kita akan, ini karena pengobatannya jangka panjang, maka utamanya yaitu gimana upaya meningkatkan kepatuhan pengobatan. Jadi kuncinya itu kepatuhan. Gimana mencegah orang itu tidak retensi terhadap perawatan HIV. Kemudian yang berikutnya adalah gimana kita bisa istilahnya itu meng-coverage anak-anak, remaja atau populasi kunci supaya mereka juga mampu mengakses ARV dengan baik. Ini summary dari guideline yang kita punya. Pada prinsipnya perubahannya cukup drastis ya. Dari yang awalnya itu kita sangat kesulitan untuk mendapatkan ARV, indikasi untuk memulai terapi ARV, sekarang makin awal makin baik memberikan ARV. Makin sederhana makin baik. Diupayakan yang rendah toksisitasnya dan monitoring yang terbaik ya. Tentunya viral load yang nanti kita akan tuju. Jadi progresnya begitu bagus sehingga secara teoritis sebetulnya tata laksana HIV itu jauh lebih bisa dimaksimalkan. Tantangannya lebih banyak pada membuat pasien itu memahami bahwa pengobatan HIV itu diperlukan jangka panjang dan keteraturan. Kembali sedikit terkait dengan patogenesis, patofisiologi dari HIV. Pada prinsipnya HIV itu akan mencari semua sel yang ada petanda CD4-nya. Begitu ternyata limfosit T memang punya petanda CD4, maka itu menjadi target. Dan dia dibantu oleh koreseptor CXCR4 dan CCR5, itu dia akan leluasa untuk masuk sitoplasma. Kemudian kan virus ini termasuk virus RNA, maka dia punya perangkat yang namanya reverse transkriptase yang mengubah dirinya RNA menjadi DNA. Sehingga dengan DNA ini dia akan leluasa masuk inti selnya. Begitu dia masuk inti sel, integrase, maka dia akan memperbanyak diri di sini, di inti sel, kemudian keluar, kemudian dengan bantuan protease dia akan memperbanyak dan siap untuk menginvasi limfosit yang lain. Prosesnya bertahap, tapi lama-lama ya semua limfosit bisa terjadi terinfeksi sehingga terjadi kelumpuhan pada imunitas. Sekarang kita lihat terapinya yang ada di dunia sekarang. Kita punya yang namanya reverse transkriptase inhibitor. Ya, tugasnya di sini untuk mencegah dia supaya tidak berubah menjadi DNA sehingga dia nggak bisa lanjut untuk berkembang biak. Yang kedua protease inhibitor, sehingga dia nggak bisa leluasa keluar dari sel. Ya. Kemudian ada yang namanya entry inhibitor, sehingga dia tidak bisa masuk pada limfosit T. Dan berikutnya adalah integrasi inhibitor, sehingga dia tidak bisa leluasa masuk ke nukleus atau inti sel. Di dunia obatnya sudah cukup banyak. Meskipun di Indonesia karena program, maka kita tidak harus mempunyai semuanya. Tapi nanti akan kita jelaskan di belakang tentang program-program yang disiapkan untuk layanan HIV. Tapi pada prinsipnya, semua pintu perkembangbiakan HIV di sel limfosit sebetulnya sudah bisa direm dengan penemuan-penemuan obat yang lebih bagus. Ini daftar obat yang tersedia di dunia, ya, cukup banyak dari masing-masing kelompok tadi. Ini yang tersedia di negara-negara maju. Ya. Kemudian ini hanya kita pengen bandingkan antara yang ARV yang disiapkan di negara maju dengan di negara Indonesia yang dikelompokkan negara berkembang. Kita lihat, di negara maju tetap kita harus memakai dua prinsip, 2 NRTI dan 2 NNRTI atau boosted PI. Jadi 3 macam obat harus dikombinasikan. Kita lihat di sini mereka punya tenofovir, abacavir, sidofudin, stafudin, kombinasi dengan emtricitabin, lamivudin, kombinasi dengan efaviren, dan obat-obat kelompok NRTI yang lain. Ya. Sedangkan di Indonesia sebetulnya sama. Kita punya tenofovir, punya sidofudin, punya abacavir, punya emtricitabin, punya lamivudin, punya efaviren, punya nevirapin, dan sekarang kita punya dolutegravir. Maksud saya, jangan sampai kita merasa inferior dibanding negara maju, karena pada prinsipnya sama, hampir mendekati sama yang dipunyai negara maju dengan yang berkembang. Nah, ini menyederhanakan regimen. Jadi kalau tadi itu 3 macam obat terpisah, sekarang sudah mulai dirancang untuk jadi satu. tugasnya hanya satu, untuk membuat kepatuhan lebih baik dengan kemudian minum obat. Gimana dengan Indonesia? Tadi sudah kita sampaikan, obatnya relatif sama dengan yang dibuat oleh negara maju. Sehingga kita tidak perlu berkecil hati dalam hal suatu saat memberikan edukasi ke pasien-pasien kita bahwa ini obat terbaik yang kita punya. Masalahnya adalah kepatuhan. Kepatuhan itu menjadi sesuatu yang prinsip di mana kepatuhan yang tidak baik akan memberikan kontribusi resistensi. Sehingga nggak ada pilihan kecuali tugas kita semua untuk mendorong pasien patuh terhadap minum obat. Kadang-kadang hal seperti ini bisa terjadi sehingga kita selalu memberikan pendampingan terbaik buat pasien, ya, karena salah satu hal yang harus kita hindari adalah terjadinya alergi berat, ya, Stevens-Johnson syndrome. Gimana cara monitornya? Begitu ARV masuk diberikan ke pasien, maka jangan sampai stop lagi. Jangan sampai berhenti. Karena prinsipnya diharapkan seumur hidup dia akan pakai dengan jadwal yang tetap dan tiap hari minum obat. Gimana cara monitornya? Prinsipnya teman-teman para klinisi, nomor satu kita punya viral load untuk memonitor, CD4 kita monitor, klinis kita monitor, dan kita juga memonitor tingkat kepatuhannya. Dan sekarang ini kebetulan hanya ada di Jakarta, yaitu melihat resistensi dari pengobatan. Ini kalau kita mau monitor dengan viral load, ya. Tadi udah kita sampaikan 90, di mana 90 yang terakhir adalah gimana upaya untuk menurunkan viral load tidak terdeteksi dalam waktu maksimal 6 bulan. Rata-rata pasien kita di poli, rumah sakit Dr. Sutomo 3 bulan sudah mencapai kadar tidak terdeteksi, sehingga sangat menjanjikan terapi yang kita berikan. Tantangan kita yang paling penting adalah kepatuhan. Dan masalahnya adalah kalau pasien itu tidak patuh, terjadi resisten, maka virus yang resisten ini akan berpindah ke orang berikutnya. Sehingga orang berikutnya nanti sangat dimungkinkan mendapatkan virus resisten sehingga dia dengan pengobatan lini 1 sudah tidak mempan lagi. Ini yang paling kita khawatirkan. Kita lihat di sini. Saya program hanya butuh 6 bulan untuk mencapai undetect. Dan ini relatif harusnya membuat kita percaya diri dalam hal menemukan kasus dan mempertahankan pengobatannya. Dan ini CD4 diharapkan stabil dalam kondisi tinggi. Dengan kondisi kayak gini, berarti kita nanti akan berharap pasien-pasien dengan HIV itu bisa hidup jangka panjang. Sehingga tantangan berikutnya adalah komplikasi yang tidak terkait dengan HIV. Sangat mungkin nanti setelah HIV-nya terkendali, maka tugas kita berikutnya adalah gimana menata kalau pasien HIV itu ada kolesterolnya, ada diabetesnya, ada penyakit jantungnya, penyakit sarafnya, itu nanti menjadi tantangan kita berikutnya. Ini harapan kita nanti pasien dengan HIV yang minum obat teratur diharapkan bisa hidup 50 tahun ke depan. Artinya, kalau sekarang dia usianya 20 pada saat ditemukan, maka silahkan dia hidup sampai usia 70 tahun ke depan. Sangat menjanjikan. Ya, ini yang tadi kita sampaikan. Nanti masalah kita adalah masalah di mana dengan komorbid yang tidak diinginkan. Ini nanti tantangan kita, HIV dengan gangguan ginjal, HIV dengan gangguan tulang, kanker, kardiovaskuler, ini menjadi tantangan tersendiri. Jadi HIV-nya sudah aman, tapi penyakit-penyakit lain akan bisa menyertai. Dan ini nanti bisa terkait dengan banyak kompetensi, termasuk teman-teman dokter gigi. Karena dokter gigi itu pintu masuk penemuan kasus, juga bisa jadi nanti pintu masuk untuk perawatan gigi. Masalahnya sekarang kalau pemahaman tidak diberikan sejak sekarang, nanti takutnya terjadi salah paham di lapangan. Satu sisi pasien takut distigma sehingga tidak mau ngaku bahwa dia pasien HIV. Satu sisi begitu ngaku ternyata tidak memberikan layanan terbaik untuk pasien-pasien HIV. Ini menjadi hal yang memang perlu disinkronkan dengan pemahaman seperti ini. Sehingga ke depan nanti diharapkan kita bisa mengakhiri epidemik ini, mau optimis atau versus kenyataannya, ini pertanyaan yang harus dijawab. Yang jelas, data-data di dunia menyebutkan bahwa ART for prevention, artinya apa? Makin cepat kita temukan, makin cepat kita berikan ARV-nya, itu sama seperti pencegahan untuk penularan berikutnya. Dan memang terbukti bahwa pasien-pasien yang mendapatkan ARV, maka resiko penularan melalui hubungan seks beresiko jauh menurun. Tapi itu tidak berlaku untuk penularan melalui darah. Jadi kalau darah itu begitu masuk ya 100% tertular. Di sini ada juga PrEP. Kalau tadi itu profilaksis pasca pajanan, teman-teman dokter gigi yang merasa tertusuk, segera lapor, kita berikan profilaksis. Kalau ini adalah PrEP, jadi sebelum melakukan faktor resiko, dia bisa memakai obat untuk mencegah penularan. Ini belum masuk program, sehingga kita belum menggunakan di Indonesia. Sirkumsisi menjadi hal yang sebetulnya udah automatically menguntungkan, karena untuk umat Islam, rata-rata melakukan sirkumsisi. Ya, ini beberapa strategi pencegahan. Kita punya ARV, kemudian perubahan perilaku, tes HIV, sirkumsisi, tapi kita belum punya PrEP dan program untuk microbicide. Masing-masing negara bisa berbeda-beda. Dan ini program pemerintah udah lengkap sekali. Masalahnya adalah sosialisasi dan mengimplementasikan di lapangan. Sehingga saya berharap teman-teman dari profesi kedokteran gigi juga memahami isu HIV sehingga jangan sampai tertular karena ketidaktahuan. Yang kedua, kalaupun mempunyai pasien dengan kondisi HIV tetap harus memberikan layanan terbaik tanpa takut tertular atau tidak memberikan layanan yang optimal. Gimana dengan era pandemi? Mungkin menurun, tapi ini menurun beneran atau karena tenaga medisnya atau pasien sendiri yang nggak tertarik untuk berkoordinasi atau berkomunikasi. Lepra TB menjadi tantangan metabolik saat ini, penyakit jantung, penyakit ginjal semua turun di poli-poli itu. Semua dikalahkan dengan isu COVID ini, sehingga harapan kita nanti COVID betul-betul mengarahkan kita dengan istilahnya AKB, adaptasi kebiasaan baru, sehingga harus berbagi. COVID ya dilayani, penyakit-penyakit lain juga dilayani. Sehingga dengan adaptasi kebiasaan baru diharapkan ya akses terhadap HIV untuk laboratorium, terapi, konseling tetap kita bisa maksimalkan. Ini hasil akhir dari pembicaraan kita selama hampir 1 jam ini. Pada prinsipnya nanti ke depan yang dibutuhkan adalah ini karena ada mahasiswanya, mungkin nanti bisa diadaptasi tentang interprofessional education, di mana teman-teman dari FK, FKG, keperawatan, atau fakultas yang lain kita bisa bareng-bareng untuk menyelesaikan beberapa penyakit yang mungkin bisa menjadi percontohan bahwa nanti ke depan memang penyakit nggak bisa diselesaikan oleh satu fakultas saja. Dan di sini udah kita siapkan masalahnya, bisa di pre-hospital, hospital maupun post-hospital. Pre-hospital ini gimana cara menemukan, hospital ini gimana cara memberikan tata laksana terbaik, baik itu terkait dengan problem gigi atau problem yang lain. Yang post-hospital ini gimana kita bisa mempertahankan layanan kita supaya pasien tetap bisa mendapatkan layanan dengan sebaik-baiknya. Tentunya nanti ke depan kita masih berharap dengan teknologi, baik itu telemedicine, aplikasi, atau yang lain. Jadi ini tetap menjadi salah satu solusi supaya semua menjadi satu kesatuan dalam menyelesaikan suatu penyakit yang memang butuh lintas sektor. Saya kira itu Dr. Desi, semoga bermanfaat. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Erwin. Ini tampaknya para partisipan juga sudah terpesona semua dengan yang dijelaskan oleh Dr. Erwin sampai mereka lupa menuliskan pertanyaan di kolom chat gitu ya. Ayo silakan buat para mahasiswa S1, profesi maupun para calon spesialis. Kalau ada yang ingin ditanyakan langsung bisa dituliskan di kolom chat. Nanti saya akan bantu untuk menyampaikan kepada pembicara ya. Oke, Dr. Erwin, terima kasih. Ini menarik sekali update-nya. Jadi basics tapi juga very updated gitu ya dok, karena ternyata ada banyak kebijakan pemerintah yang sudah mengikuti perkembangan gitu ya. Karena kita sebenarnya sudah dealing with this pandemic itu kan sudah cukup lama ya dok ya. Pertama kali kasus itu ditemukan tahun 81 di Amerika gitu kan. Nah itu di Indonesia sendiri mungkin tahun 90-an ya dok ya kita mulai. Jadi sebenarnya memang seperti kata dokter tadi, kita sudah lama gitu kan mulai ngurusi ini sampai akhirnya menemukan strategi terbaik, apa tadi tailor tadi apa penjahitnya itu sudah mulai menata kira-kira untuk negara kita itu pasnya gimana gitu. Nah, tapi kan kayaknya tetap aja membutuhkan peran dari begitu banyak pihak ya dok ya untuk mengatasi hal ini bersama-sama. Ini yang menarik tadi ada beberapa poin yang mungkin nanti bakal jadi pertanyaan para peserta. Terutama tadi kata-kata Dr. Erwin yang pertama-pertama tadi, pasien di Indonesia itu nasibnya orang HIV kena di Indonesia gitu ya. Karena Indonesia negara tropis, banyak sekali kuman-kuman tropisnya gitu sehingga nah ini dok, saya sempat beberapa waktu yang lalu itu berdiskusi dengan rekan spesialis oral medicine dari King's College University di London. Beliau itu mengatakan bahwa dia sudah tidak pernah lagi melihat adanya oral manifestations dari HIV di sana. Jadi orang-orang HIV di sana itu hidup itu sudah infection free gitu. Nah, jadi mungkin ini tantangan buat kita ya dok ya, gimana kita juga bisa memanage pasien di Indonesia ini supaya bisa sampai seperti itu juga gitu. Nah risiko dari terkena infeksi ini apa memang murni karena negara yang tropis ini atau memang ada kerentanan dari pasien di Indonesianya, orang Indonesianya secara genetik dok?
Iya. Jadi tetap infeksi itu ada 3 hal yang harus kita pertimbangkan ya, antara host, agent, environment. Ya. 3 ini menjadi isu yang tetap jadi satu kesatuan yang harus dimaknai secara lengkap. Ya. Meskipun apa yang saya pahami di lapangan menunjukkan bahwa kenapa di luar negeri itu infeksi oportunistiknya rendah. 1, itu bisa terjadi karena penemuan dini. Dengan penemuan dini, sehingga CD4-nya masih relatif baik di atas 400. Sehingga nggak perlu sampai infeksi oportunistik karena imunitasnya sudah cukup untuk bisa mencegah jangan sampai infeksi tumpangan tadi itu masuk. Itu 1. Yang kedua, higiene sanitasi dari lingkungan. Jadi sumber air mereka, pengelolaan sampah dan sebagainya membuat mereka ya hidup dengan situasi bersih, pasti kuman-kuman juga nggak semudah itu tumbuh. Terus yang ketiga, ya memang situasi, di mana situasi dengan kelembapan rendah, sehingga kuman contohnya kayak di Arab Saudi aja, orang mau nggak ganti baju 5 hari pun nggak ada masalah, karena jamur di sana relatif nggak mudah tumbuh. Ya. Bandingkan dengan Indonesia, pagi dipakai keringatan, sore nggak cepat diganti, ya pasti jamur akan mudah sekali tumbuh. Dan yang paling jadi kunci sekarang adalah ARV. Begitu pasien ketemu langsung dikasih ARV, diharapkan dia imunitasnya nggak sampai jatuh benar, sehingga itu mengunci kenapa IO di luar negeri sudah relatif berkurang, dan kita pun mengarahnya harusnya ke sana. Itu Dr. Desi.
Ya, betul sekali dok ya. Jadi memang personal hygiene itu sangat penting dan mungkin kita seperti kata tadi dari pihak dokter gigi ini bisa membantu juga mensosialisasikan, mengedukasi pasien untuk bagaimana menjaga oral hygiene tadi sehingga mencegah lebih baik daripada mengatasi gitu ya dok. Karena mengatasi kasus infeksi pada pasien HIV itu tidak seperti mengatasi pada pasien yang normal. Oke dok, ini udah mulai banyak pertanyaan di chat. Ini ada dari residen ilmu penyakit mulut ini. Dari residen ilmu penyakit mulut ini menanyakan, mungkin terkait rapid test HIV dok, itu bolehkah dilakukan di tempat dokter pribadi, di praktek dokter pribadi gitu. Jadi mungkin berkaitan dengan PITC yang prosedurnya mungkin berbelit atau gimana, kalau memang kita sudah mencurigai atau mensuspek adanya suatu kemungkinan infeksi HIV, bolehkah langsung dilakukan rapid test di praktek dokter gigi? Silakan dok.
Ya, baik. Ini berarti isunya adalah isu penemuan kasus. Ya. Penemuan kasus itu kita bisa melakukan dengan dua cara, yaitu VCT dan PITC. VCT itu Voluntary Counseling and Testing. Artinya, mohon maaf, dokter gigi ikut pelatihan VCT 5 hari, setelah itu boleh melakukan penemuan kasus di area di mana beliau bekerja. Ya, sebagai konselor tapi. Ada beberapa yang sudah kita latih, mohon maaf, di puskesmas, di rumah sakit, kita latih menjadi konselor, ada. Ya. Ada juga yang melalui pendekatan PITC, Provider Initiative Testing and Counseling. Dulu pernah kita latih 1 hari apa 2 hari dulu ya teman-teman dokter gigi. Setelah itu, apakah boleh melakukan penemuan kasus di tempat? Boleh. Ya, karena di situ kita udah latih gimana tata cara untuk menawarkan tanpa harus memaksa, menunjukkan manfaatnya, kemudian gimana cara tesnya. Sehingga dengan begitu, kalau misalkan mohon maaf, teman-teman dokter gigi yang berada di puskesmas, di situ sudah ada tim yang dilatih untuk pemeriksaan laborat, terutama rapid, udah dituntaskan di puskesmas itu untuk diagnostik. Ya. Jadi beda dengan yang dulu. Kalau dulu kita curiga dikirim ke konselor. Nah, sekarang dengan PITC curiga ditawarkan di tempat, dites di tempat, hasilnya sudah ada, baru dirujuk bila ada dibutuhkan tata laksana lebih lanjut. Itu Dr. Desi.
Ya, terima kasih Dr. Erwin. Jadi memang harus ikut pelatihan dulu ya untuk menjadi seorang konselor, dan bahkan untuk PITC pun demikian. Ini mungkin sekaligus menjawab pertanyaan dari residen IPM lainnya di sini, Dr. Rosalin ini juga menanyakan bagaimana apakah dokter gigi bisa menjadi konselor pada tim penanganan HIV. Jawabannya berarti bisa ya dok ya, asalkan meluangkan waktu 5 hari untuk ikut pelatihan itu memang yang dilakukan, yang memang sudah ada pakemnya itu gitu. Nah, kemudian ini ada menarik mengenai pertanyaan mengenai ARV, dok. Nah, tadi ini Dokter Afrila, ini dari residen ilmu penyakit mulut juga, ini menanyakan, tadi Dokter Erwin mengatakan bahwa ARV itu dapat membunuh HIV gitu. Padahal kita pelajari bahwa ternyata cara kerjanya ARV itu adalah menghambat replikasi virus. Menghambat virus supaya tidak bisa masuk, menghambat virus supaya tidak bisa berreplikasi ya, melakukan reverse transkriptase itu, berintegrasi dan keluar lagi. Nah, jadi kenapa kok dengan begitu dia dikatakan bisa membunuh HIV? Itu yang ditanyakan ini dok.
Ya, baik. Ini hanya masalah istilah pembunuh apa enggak ya. Artinya gini, tadi udah kita sampaikan 90, di mana 90 yang terakhir itu dalam 6 bulan, berapapun jumlah virus, begitu 6 bulan dites ulang, diharapkan undetect, tidak terdeteksi. Berarti kan dari jutaan, ratusan ribu, berarti setelah kita berikan ARV, diharapkan dalam 6 bulan tidak terdeteksi. Artinya apa? Jumlah virusnya sangat minimalis. Nah, sangat minimalis itu yang dalam tanda kutip gini, kita pengen marketing ke pasien itu juga meyakinkan ya. Jangan sampai, mohon maaf, begitu kita bilang hanya menidurkan atau memperpanjang usia, membuat pasien juga nggak termotivasi. Sehingga yang kita mau ya, ayolah kita buat statement yang proporsional. Kalau memang virusnya betul-betul dari jutaan menjadi sangat minimalis, kalau itu pakai, mohon maaf, saya nyebut merek, di Prodia gitu ya, alat untuk tes HIV, mungkin sangat akurat sekali. Dia tidak mendeteksi setelah jumlah virusnya 20 kopi per cc. Kalau kita pakai punyanya Sutomo masih 400 kopi per cc, dianggap tidak terdeteksi. Artinya apa? Sangat-sangat kecil jumlahnya itu. Nah, dengan begitu tadi, maka diharapkan virusnya nggak ganggu CD4, sehingga CD4-nya akan bangkit sendiri, sehingga imunitasnya sama seperti orang normal. Makanya orang-orang dengan HIV yang berhasil untuk teratur minum obat, jangka panjang dia akan hidup normal lagi. Kira-kira itu, Dr. Desi.
Terima kasih Dr. Erwin. Ya, ini berarti adalah teknik komunikasi pada pasien ya sebenarnya Dok ya. Cuman kan memang kita juga sebaiknya tidak menjual mimpi gitu ya Dok ya. Nanti dibilang PHP gitu, memberi harapan palsu. Ya, tapi supaya pasien comply dengan apa yang kita instruksikan, dan pasien juga jadinya bisa patuh dalam mengikuti regimen terapi yang diberikan gitu ya. Terus ini Dok, kalau tadi ada disampaikan bahwa obat ARV itu bisa sampai menyebabkan alergi ya Dok ya. Stephen Johnson itu kan berarti kan suatu reaksi hipersensitivitas gitu. Mungkin kalau di bidang kami yang biasa kami tangani itu eritema multiform Dok, sebatas eritema multiform. Jadi yang masih hanya di sekitar bibir gitu. Ketika sudah mulai ada lesi target yang muncul di kulit, itu biasanya kita harus bekerja sama dengan spesialis terkait. Nah, apakah ada efek lain Dok yang harus diwaspadai juga selain Stephen Johnson ini Dok?
Ada, tapi saya mau bahas dulu tentang Stephen Johnson sendiri. Ketika saya tanya kepada PPDS kami, kenapa kok bisa jadi Stephen Johnson? Itu karena edukasi yang kita berikan satu kurang fokus, sehingga tidak menyampaikan bahwa kemungkinan terjadi alergi dan seterusnya. Yang kedua, kita tidak memberikan akses, nomor HP kita ke pasien. Sehingga pada saat pasien itu masih ringan, mungkin hanya gatal-gatal sedikit, karena nggak punya akses ke kita, maka mungkin dia tanya tetangganya, temannya, saudaranya, yang kadang-kadang kesimpulannya itu dianggap ini obatnya lagi bekerja, sehingga diterusin obatnya. Begitu diterusin ya Stephen Johnson. Ya. Jadi yang kita lakukan di Rumah Dr. Sutomo, satu, pasien dapat edukasi lengkap, yang kedua boleh dapat nomor HP kita, sehingga nanti apapun problemnya harus cepat lapor. Kemudian terkait dengan efek lain, iya. Jadi kita punya kurang lebih 7 macam obat yang nanti kita harus kombinasi-kombinasi itu mencapai target kerja obat. Pada prinsipnya masing-masing punya efek samping. Contoh, nevirapin tadi selain SJS juga bisa gangguan fungsi hati. Efaviren itu ganggu susunan saraf pusat, rasanya gliang, kemudian mimpi buruk itu bisa terjadi. Kemudian terjadinya ginekomasti, kemudian gangguan profilip itu juga bisa terjadi. Kemudian sidofudin itu kadang-kadang bikin mual, wah luar biasa itu mualnya. Kalau terjadi, tapi tetap semua itu, mohon maaf, hanya 5%. Tapi tetap harus kita sampaikan. Ya. Jadi nggak semuanya terjadi efek mual. Banyak pasien-pasien dengan penggunaan sidofudin sampai sekarang ya aman-aman ada. Sehingga prinsipnya satu, individual dalam pemilihan kombinasi regimen itu menjadi isu penting terkait dengan kenyamanan pasien untuk minum obat jangka panjang.
Ya, ya Dok, betul Dok. Ini memang harus dipegang sama kita semua, baik para calon dokter gigi maupun yang dokter gigi spesialis, sebagian sudah praktek ya. Kalau kita meresepkan obat apapun sebenarnya, kalau kita meresepkan obat, maka harus disampaikan pada pasien efek apa yang expected akan terjadi, baik itu efek utama maupun efek samping yang mungkin terjadi, itu harus disampaikan. Dan disampaikan juga bila terjadi efek yang di luar yang kita sampaikan tadi, segera kembali pada kami, segera hubungi kita kembali untuk kita assess apakah itu memang suatu adverse reaction atau hypersensitivity atau intoksikasi gitu. Nah, itu perlu kita waspadai betul. Baik, terima kasih Dok. Kita lanjutkan ke pertanyaan berikutnya. Nah, Itu tadi yang tentang efek samping ARV tadi juga ditanyakan oleh residen ilmu penyakit mulut. Nah, selanjutnya sekarang ini dok. Nah, pasien HIV itu kan seringkali dapat infeksi yang rekuren. Contohnya tadi dokter mengatakan herpes zoster. Kita juga beberapa kali mendapatkan kasus infeksi herpes simplex dok, yang rekuren, yang highly recurrent. Biasanya kan herpes simplex itu paling kan apa tuh? Jadi herpes labialis itu kan mungkin kalau pas kena paparan sinar UV atau pasiennya kelelahan banget, stres gitu. Tapi kan rekurensinya tuh nggak terlalu sering. Nah, kita pernah dapat kasus yang memang hampir sebulan sekali itu kumat gitu. Nah, jadi kan memang rekurensinya itu tinggi. Nah, bagaimana dok di sini ini cara mengatasi infeksi yang rekuren bahkan persisten? Ini pertanyaan dari Dokter Ida Bagus Pramana. Nah, tata laksananya bagaimana tepatnya gitu untuk pasien-pasien yang memang mengalami infeksi yang rekuren bahkan persisten?
Ya, baik. Saya bagi dua dulu. Saya bagi dua yang belum dapat ARV sama pasien yang sudah dapat ARV. Kalau yang belum dapat ARV, itu situasi yang dalam tanda kutip normal untuk natural historinya. Jadi yang belum dapat ARV dengan CD4 yang rendah, wajar lah sekarang diobati, besok kambuh lagi dan seterusnya. Itu bukan hanya terjadi di penyakit gigi mulut aja, kondiloma pun juga bisa terjadi. Kadang-kadang sudah dilakukan kauter, nanti tumbuh lagi. Ya, jadi itu kalau sebelum diberikan ARV menjadi natural history dari penyakitnya. Kalau misalkan itu terjadi setelah diberikan ARV, dibagi dua lagi, yang mengawali ARV sama yang sudah lama. Ya. Kalau yang masih mengawali ARV, hati-hati dengan yang namanya sindroma pulih imun. Ya. Sindroma pulih imun itu karena ARV bekerja dengan sangat baik, sehingga jumlah virusnya turun drastis, CD4-nya naik drastis, penyakit-penyakit subklinis itu kadang-kadang muncul. Ya, itu bisa terjadi pada TBC atau penyakit-penyakit yang memang ada di situ, tapi karena faktor sindroma pulih imun sehingga terkesan bahwa dikasih ARV kok tambah jelek kondisinya kan gitu. Nah, itu hati-hati. Kenapa? Karena obatnya bukan nyetop ARV-nya, tapi obatnya adalah memberikan steroid dosis kecil selama 2 minggu. Nanti kalau irisnya udah baik, biasanya keluhan-keluhan itu akan hilang sendiri. Yang ketiga, kalau sudah lama sekali dapat ARV, tahu-tahu muncul lagi, hati-hati terhadap kemungkinan resistensi ARV. Jadi sudah minum lama kok tahu-tahu muncul lagi, ya berarti monitoring klinis yang kita lakukan. Karena teoritis dengan ARV yang tadi kita sampaikan, 6 bulan harusnya virus undetect, kenaikan CD4-nya 100 per tahun, berarti harusnya setelah setahun 2 tahun ya harusnya udah aman dari recurrent. Nah, kalau masih recurrent, kita butuh data sekarang untuk viral load sama CD4. Kalau terbukti masih CD4-nya masih rendah, maka sesegera mungkin untuk dievaluasi ARV-nya, kalau perlu diganti. Sehingga dengan begitu tetap kita bermainnya pada kausatif ya. Jadi imunitas betul-betul harus bangkit dengan mengefektifkan ARV dalam mengeliminasi virus yang ada. Itu kira-kira.
Ya, terima kasih dok. Berarti ini iris ya dok ya, anunya ya, risikonya ya.
Kalau masih
ya,
awal.
Kalau di awal pemberian ARV. Nah, jadi itu tadi dokter Pramana jawabannya ya. Jadi kita bagi dulu apa memang pasien ini adalah pasien yang belum menggunakan ARV. Biasanya yang sering kita hadapi adalah yang masih belum menggunakan ARV ya. Jadi yang bahkan belum tahu kalau dia ternyata HIV positif gitu. Nah, ini. Oke, baiklah. Selanjutnya ini dari Dr. Kurnia sudah terjawab ya tadi ya, bagaimana agar pasien patuh minum obat. Ini juga sudah termasuk yang tadi sudah dijelaskan Dr. Erwin. Jangan menjual mimpi tapi ya. Kemudian, nah ini ada pertanyaan yang bagus sekali dari mahasiswa S1 ini atas nama Nadia Latuar Muri. Nah, ini kalau PEP dok, PEP kalau seorang nakes tidak sengaja terkena jarum suntik dari pasien ODA. Nah, apakah memang langsung diberikan profilaksis atau kalau misalnya pasiennya ternyata tidak ODA gitu. Jadi langsung diberi profilaksis aja, melihat pasien itu ODA atau bukan, atau memang hanya khusus kalau pasiennya udah pasti ODA baru si nakes itu dikasih profilaksis. Gitu, Dok.
Oke. Nah, ini Dr. Desi. Yang jelas satu, prinsip profilaksis pasca pajanan ini harus dipahami oleh teman-teman tenaga medis. Ya. Saya sederhanakan, yang penting tugasnya satu, lapor. Tidak perlu memikirkan apa yang terjadi. Kenapa? Karena nanti kita berbagi tugas. Misalkan ada teman-teman dokter A, anestesi atau dokter bedah, operasi, tertusuk, tugasnya dia tidak memikirkan apa yang harus saya lakukan untuk penanganan profilaksisnya, tapi lapor untuk mencari akses ke kita. Nanti kita yang akan ngitung, menghitung faktor resiko tadi, derajat ringan, sedang atau berat. Contoh, ada pasien dokter muda bekerja di puskesmas menangani pasien hamil terus tertusuk Sabtu malam Minggu. Karena golden period untuk profilaksis ini 4 jam, maka kita biasanya membuat keputusan minum dulu ARV profilaksis. Kenapa? Mikirnya belakangan. Nanti setelah hari kerja pasien kita tes ternyata negatif, maka obat ARV profilaksis bisa kita stop. Tapi kalau ternyata, mohon maaf, pasiennya positif, sudah aman karena sudah minum ARV dari awal. Jadi kalau ragu-ragu kita anggap berat, sehingga kita anjurkan minum dulu sampai yakin bahwa pasien itu betul-betul dalam kondisi positif atau negatif dan seterusnya. Ya. Jadi
assume the worst ya, Dok ya.
Betul, betul.
Baik, baik. Dok, tapi kalau misalnya itu terjadi pada dokter yang praktek pribadi gitu, dia harus melaporkan diri kemana, Dok, untuk mendapatkan profilaksis pasca pajanan?
Satu, profilaksis itu program, dimanapun bisa ngambil. Yang jadi masalah adalah tim untuk memfasilitasi itu ada enggak gitu. Kalau Sutomo enak, wis telepon saya, nanti kita dorong supaya tim Sutomo membantu untuk menyiapkan obat saat itu juga 24 jam. Dan ini yang paling dapat manfaat biasanya anestesi sama bedah, karena mereka sudah membuat ya sedikit protap enggak formal gitu, pokoknya kalau ada yang tertusuk segera lapor saya misalkan, sehingga mereka banyak kebantu. Kapanpun mengalami kecelakaan kerja, segera kita bantu.
Iya. Mungkin kalau gitu, kalau dari praktek pribadi gitu, segera ke rumah sakit terdekat aja ya, Dok ya, kalau gitu ya. Baik. Selanjutnya, Dok. Nah ini kalau pertanyaan dari Nadia ini, bagaimana cara komunikasi yang tepat supaya pada waktu anamnesis pasien dapat terbuka gitu ya. Nah ini Nadia harus ikut kursusnya tadi untuk jadi konselor tadi gitu ya. Baik. Nah selanjutnya ini ada pertanyaannya juga bagus dari Dr. Niputri Skayanti, dari residen penyakit mulut juga. Ini kalau pasien mau dilakukan tindakan kedokteran gigi, apakah memang bisa, Dok, kita meminta pasien untuk melakukan pemeriksaan darah atau CD4 dulu kalau memang kita curiga ya, kalau kita curiga memang ada suspek HIV dan mau dilakukan tindakan dental, apakah boleh kalau memang pasien dirujuk dulu untuk pemeriksaan HIV dan CD4. Terus kalau misalnya pasien menolak, apakah apa yang harus kita lakukan gitu, Dok? Apa kita juga sebagai dokter gigi kita juga boleh nggak, Dok, menolak? Ya udah kalau itu saya juga nggak mau ngerawat kalau Anda juga nggak mau diperiksa. Kayak gitu mungkin, Dok. Silakan, Dok.
Oke. Yang nomor 1 tadi terkait dengan gimana cara komunikasi kepada pasien supaya mau terbuka. Prinsipnya satu, tunjukkan manfaatnya. Bahwa kalau terbuka itu berarti kita bisa memberikan tata laksana yang lebih komprehensif misalkan. Jangan sampai kita tunjukkan bahwa kita mau siap-siap menstigma pasien itu. Itu yang paling penting. Ya. Selama mereka dapat kepastian bahwa mau terbuka apa enggak itu menjadi bagian dari manfaat ke pasien, biasanya mereka akan terbuka. Ya. Jangan kalau untuk kepentingan dokternya kalau memang terbuka itu. Kalau untuk kepentingan dokter biasanya wah ini ketir-ketir mereka mau terbuka malah biasanya nggak tertarik. Kemudian yang kedua, apakah tindakan bedah atau apapun itu memerlukan tes HIV? Ada dua isu yang kita tawarkan. Isu yang pertama mesti saya kembalikan pertanyaannya. Ini tes HIV ini dokter safety atau patient safety? Kalau dokter safety tidak pada tempatnya untuk memaksa pasien tes HIV. Kenapa? Karena isu dokter safety itu ada di universal precaution. Ya. Jadi kalau pengen aman, justru anggap aja semua pasien kita HIV, sehingga kita memakai standar precaution yang terbaik. Itu kalau dokter safety. Ya. Sehingga kalaupun pengen memaksa pasien dalam tanda kutip untuk tes HIV, itu harus dikembalikan manfaatnya untuk patient safety. Memang untuk kepentingan pasien. Jadi contohnya gini, misalkan ada pasien mau pembedahan otak, kita curiga kesadaran turun ini karena HIV atau bukan, maka kita perlu tes. Sebab kalau dengan mengetahui data itu pasien HIV, maka dengan mudahnya kita membuat diagnosis bahwa ini problem otaknya karena toksoplasma, bukan karena tumor misalkan. Nah, itu harus dirancang untuk kepentingan pasien. Sehingga jangan sampai nanti ada kasus-kasus misalkan di rumah sakit swasta sudah kolik abdomen, begitu dites hasilnya positif nggak jadi operasi, itu kalau bisa hindari. Kenapa? Ya bukan patient safety berarti, karena harusnya tes hasilnya HIV apapun harusnya tetap diberikan layanan dengan sesuai kompetensi dan sesuai dengan layanan yang mau diberikan. Kira-kira itu.
Itu prinsip justice ya, Dr. Erwin ya.
Ya,
jadi kalau dalam etika itu ada justice, di mana semua pasien memang layak mendapatkan pelayanan yang sama. Dan ya tadi saya sepakat sekali dengan Dr. Erwin bahwa kita sebagai dokter gigi harus melihat dari isunya kepada manfaat buat pasien gitu. Sementara dokternya ya memang harus menerapkan universal precaution yang harus diterapkan untuk semua pasien gitu. Semua pasien dianggap bisa menularkan dan bisa tertular. Ya dok, kemudian sekarang harusnya sih memang kalau untuk perawatan kedokteran gigi, memang kalau dari sisi patient safety, itu pemeriksaan CD4, pemeriksaan kadar neutrofil itu sangat penting sekali karena kita perlu memastikan bahwa pasien ini nanti aman gitu pada waktu dia menjalani terapi dental. Apalagi kalau terapi dentalnya invasif seperti pencabutan gigi, seperti itu. Ya, baiklah. Kemudian selanjutnya ini dok, ini menarik sekali dok pertanyaannya. Tadi kan kayak ada kasus Stephen Johnson syndrome gitu. Tadi saya sempat menyinggung kalau yang masih di kita mungkin kena masih belum sampai SJS, tapi mungkin EM, erythema multiforme. Mungkin bukan karena obat ARV, tapi bisa jadi karena obat antibiotik yang dia minum gitu. Karena kan kita tahu pasien HIV itu kan minum obatnya banyak banget ya dok. Nah, jadi siapa tahu ada salah satu obatnya yang memang memicu reaksi dari hipersensitivitas. Nah, mungkin datang ke kitanya karena bibirnya aja dok yang melonyoh-melonyoh gitu kan ya. Nah, jadi EM. Nah, pada kondisi seperti itu biasanya treatment of choice kita adalah kortikosteroid. Nah, ini ada pertanyaan dari residen IPM. Kortikosteroid itu apa boleh digunakan untuk pasien HIV dan golongan kortikosteroid apa yang aman untuk digunakan? Begitu, dok.
Oke. Gini. Begitu ada istilah Stephen Johnson atau erythema multiforme tadi, maka langkah terbaik adalah nyetop penyebabnya. Itu yang paling penting. Ya. Jadi kalau misalkan yang kita curigai karena ARV, ya maka ARV-nya di stop. Kalau kita juga karena anti nyeri, karena beberapa obat anti juga bisa bikin alergi, antibiotik, ya kita stop dulu itu. Itu yang paling penting. Yang kedua, memang terjadi perbedaan filosofis ini antara, kalau saya membandingkan di rheumatoid itu antara penyakit dalam konsultan alergi dengan kulit. Kalau kulit itu agresif sekali. Dia selalu memberikan antihistamin dengan steroid. Sedangkan untuk penyakit dalam lebih condong pada menggunakan antihistamin saja. Ya. Tapi bagi saya nggak ada masalah, dua-duanya bisa dilaksanakan. Yang penting bagi saya adalah penyebabnya segera dicari, kalau ragu-ragu ya stop semua terapinya. Yang dicurigai menjadi penyebab SJS atau alergi tadi. Steroid yang dipakai, betulnya macam-macam. Bisa dari kelompok metilprednisolon, bisa kelompok dexamethasone, ya itu bagian dari kebiasaan masing-masing dokter. Saya sendiri relatif jarang sekali pakai steroid. Jadi saya lebih cenderung monitoring dengan antihistamin. Yang penting penyebabnya kita stop duluan. Saya kira itu yang sering saya lakukan tanpa menggunakan steroid dulu. Apakah boleh steroid untuk HIV? Boleh kalau ada indikasi. Yang penting diukur kemanfaatannya dan kalau bisa tidak untuk jangka panjang.
Ya, oke dok, itu jawabannya top sekali. Jadi ya memang ya dok ya, cuman kalau kita bisa tahu intinya kan kondisinya itu yang mana yang life threatening itu yang diatasi dulu gitu kan ya dok ya. Obat ARV nanti bisa diganti gitu. Tapi ini karena kondisi alergi yang seperti ini kan berbahaya gitu ya. Nah tapi kalau bisa dihindari atau kalau bisa diberikan hit and run gitu berarti ya dok ya, secepat mungkin kemudian segera dihentikan gitu masih bisa gitu ya berarti penggunaan steroid itu ya dok ya. Oke, terima kasih dok. Nah selanjutnya ini wah banyak dok pertanyaannya dok, tapi mudah-mudahan waktunya masih cukup sedikit lagi. Ini dok. Jadi prinsip ESSA tadi dok, exit, survive, sufficient, dan enter. Itu kalau dari segi seberapa banyak sih dok virus yang dibutuhkan gitu ya untuk dia tuh bisa menular gitu, karena kan anggaplah kita mau melakukan suatu tindakan kedokteran gigi yang invasif kayak mencabut gigi gitu kan langsung akan terjadi perdarahan gitu. Nah itu viral load-nya mungkin ya dok ya seberapa banyak yang di sini berisiko untuk bisa langsung menular gitu, atau jadi supaya kita tahu seberapa banyak yang masih dalam posisi aman gitu dok.
Saya kembalikan pada dua rute utama untuk virusnya leluasa masuk. Yang satu dari narkoba suntik atau akses injeksi spuit yang masuk ke dalam tubuh pasien. Itu 100%. Karena sedikit apapun, satu tetes, setengah tetes, seperempat tetes, ada satu virus misalkan yang udah masuk, ya udah 100% udah masuk. Nah, saya bergeser ke hubungan seksual. Hubungan seksual itu dia 100%. Kecil sebetulnya, di bawah 10%. Ya. Dan kalau dia minum obat, maka lebih rendah lagi. Mungkin nggak sampai 5%, nggak sampai 3%. Sehingga kenapa filosofi treatment as prevention itu menjadi isu penting supaya viral load-nya betul-betul rendah. Kalau undetect maka khususnya ini untuk hubungan seks beresiko maka dia akan kebantu untuk ikut turun resiko penularannya. Tapi ini tidak berlaku untuk hubungan darah. Jadi kalau kontak darah, dalam arti kontak darah bukan kecipratan darah loh ya, tapi dibuatkan akses melalui misalkan pembuatan foto, jarum suntik, kemudian pemakaian jarum yang tidak disposable itu yang bikin masalah. Jadi berapapun kadarnya ya kalau udah jarum suntik ya 100% masuk.
Oke dok, bagaimana dengan kalau tercipratnya pada mukosa dok, kayak mukosa mata atau mukosa mulut?
Mukosa itu termasuk resiko, ya. Memang tidak 100% seperti darah, tapi dia lebih tinggi dibanding hubungan seksual tadi. Misalkan kecipratan pada mata, kemudian diucek, itu berarti punya potensi. Nah itu sudah masuk ranah kategori sedang sampai berat sehingga sangat memerlukan ARV profilaksis.
Ya.
Karena mukosa punya pintu yang bagus juga untuk masuk lewat sana. Apalagi kalau misalkan di situ ada perlukaan, itu lebih kelihatan lagi masuknya.
Ya, betul dok. Ya, apalagi memang secara penelitian juga terbukti bahwa memang pada mukosa itu ada reseptor-reseptor pada sel epitelnya itu ada reseptor yang memudahkan ikatan antara virusnya itu dengan mukosa. Jadi nanti dia bisa nempel dulu di situ dan ketika nanti ada yang tracking atau apa dia jadi bisa masuk gitu. Oke dok. Nah ini mungkin saya imbuh satu pertanyaan lagi ya dok ya sebelum terakhir ya. Yang lain mohon maaf kalau tidak terjawab ini karena ya waktu juga yang membatasi kita. Tapi nanti mohon izin dok ini nanti chatnya saya copy semua lalu saya kirim ke Dokter Erwin ya dok ya. Nanti barangkali dokter sambil agak ada waktu senggang bisa dibales gitu ya dok ya. Nanti dikirim lewat panitia ke pesertanya. Ini ada satu pertanyaan terakhir mungkin di sini dok. Kan kita kan nanti akan ada tiba masanya di mana semua pasien HIV itu udah rajin minum ARV gitu ya dok ya, seperti kayak yang saya ceritakan di Inggris tadi itu yang dokter spesialis penyakit mulut dari Inggris tadi. Nah jadinya kita akan dealing dengan pasien yang memang mengkonsumsi HAART dalam jangka panjang gitu. Nah, ada nggak dok manifestasi dari terapi jangka panjang atau terapi HRT pada umumnya lah dok, jadi nggak usah jangka panjang. Ya kalau pasien itu minum antiretroviral kombinasi tadi, nah itu apakah ada manifestasinya yang tampak secara klinis mungkin di tubuhnya? Dan kalau nanti di rongga mulutnya itu tugas kita nanti mencari dok. Tapi kalau yang secara klinisnya aja deh dok, kelihatan nggak dok? Apa tambah gemuk misalnya atau ada hiperpigmentasi mungkin apa dok ya?
Betul, ada tapi nggak banyak. Contohnya tadi yang saya sampaikan ya, misalkan ginekomasti. Ginekomasti itu ada yang payudara sampai membesar, laki, dan memang kita udah koordinasi dengan bedah plastik, tapi pasiennya masih ragu-ragu untuk melakukan pembedahan.
Laki-laki padahal dok?
Laki-laki. Kemudian bisa juga terjadi dislipidemia, itu memang harus dilihat dari petanda laboratorium. Biasanya trigliseridnya yang tinggi sekali. Ya. Kemudian terjadi lipodistrofi. Lipodistrofi itu perlemaan atau tumbuhnya lemak pada tempat-tempat yang nggak kita inginkan, tapi hilangnya lemak pada tempat yang harusnya ada. Jadi betisnya itu kadang-kadang kecil, pahanya kecil, kemudian pipinya juga cenderung mengecil, tapi di belakang sini kelihatan besar sekali. Ya, lipodistrofi itu yang kadang-kadang membuat sebetulnya itu lebih cenderung ke arah kosmetik, nggak nyaman untuk pasiennya. Ya. Tapi tetap aja itu menjadi bagian dari evaluasi kita. Kalau memang dirasakan sangat mengganggu, maka biasanya kita change, kita substitusi ke regimen yang lain, sehingga diharapkan mereka tetap harus hidup nyaman dengan ARV yang kita punya.
Ya dok, mungkin itu jadinya bisa tanda-tanda itu jadi bisa membantu dokter gigi untuk mengenali. Jadi memang mungkin kan tidak mudah tadi menggali dari pasiennya bahwa dia adalah seorang pasien ODA, bahwa dia dalam menjalani terapi HART gitu ya dok ya. Mungkin juga penting tadi dokter Erwin kan menjelaskan pada kita semua nama-nama obat ARV ya apa saja. Nah itu para dokter gigi harus tahu itu nama obat-obat itu. Jadi kadang kita kan dalam anamnesis kita menanya mungkin pasien nggak mengakui ya kalau ditanyai ada penyakit sistemik apa, tapi ketika kita tanya apa ada konsumsi obat secara rutin yang diminum setiap hari, nah dia mungkin mengatakan oh ya saya minum sidofudin dok, nah gitu kita tahu oh sidofudin itu adalah golongan ARV itu gitu, nah kita jadi bisa punya alert gitu kan ya, seperti itu. Baik, kalau begitu sayang sekali ini benar waktunya sudah benar-benar habis ini. Jadi terima kasih yang sebesar-besarnya saya ucapkan pada Dr. Erwin atas sharingnya, materinya yang sangat menarik. Kemudian tanya jawabnya juga semuanya memuaskan, bisa menjawab dengan komprehensif semua ini. Dan bagi yang belum terjawab tadi, mudah-mudahan tadi Dr. Erwin masih berkenan untuk menjawab melalui text message. Selanjutnya saya kembalikan kepada pemandu acara untuk penutupan. Silakan.
Ya, terima kasih Dr. Desi. Jadi kita sudah sampai pada akhir Stovit Online Series yang sesi 3, yaitu sesi terakhir. Terima kasih banyak kepada pembicara Dr. Erwin untuk bisa memberikan materi yang sangat menarik ya, dan juga kepada mahasiswa, adik-adik mahasiswa S1 maupun dari residen ya, jadi mahasiswa program residensi di spesialis penyakit mulut ataupun yang spesialis lain, saya lihat juga ada beberapa. Saya mohon untuk pembicara dari Dr. Erwin, kemudian dosen dari Departemen Ilmu Penyakit Mulut, serta residen dari program spesialis ilmu penyakit mulut untuk tetap bisa berada di tempat dahulu untuk melakukan foto bersama. Dan untuk mahasiswa, sesi Stovit online series ini sudah berakhir, dan jangan lupa untuk menyerahkan tugas dari resume webinar kali ini. Ya, semoga bermanfaat bagi adik-adik mahasiswa maupun dari mahasiswa program residen, dan sampai berjumpa di Stovit online series berikutnya. Ya, kami harap untuk pembicara, dosen Departemen IPM dan juga residen untuk tetap berada di tempat untuk sesi foto bersama. Ya, Assalamualaikum warahmatullahi wabarakatuh. Terima kasih banyak. Selamat siang.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Ayu. Saya ucapkan terima kasih kepada dua pemateri pada SOS pagi hari ini, Dr. Azlan Jafar dan Dr. Erwin Asta Triyono. Berikutnya saya juga ingin mengucapkan terima kasih mewakili tim SOS kepada Departemen IKGM dan Departemen IPM yang pada pagi hari ini sudah menyiapkan SOS dengan begitu bagusnya, dengan begitu baiknya acara dikemas. Kemudian saya juga ingin mengucapkan terima kasih kepada seluruh residen yang telah hadir mengikuti acara SOS kita pada pagi hari ini. Adik-adik juga. Berikutnya saya ingin menginformasikan tentang kegiatan SOS kita berikutnya pada tanggal 19 Oktober 2020 di hari Senin pada pukul 12.30. Kami dari Departemen IKGM ini akan menghadirkan pembicara tamu Dr. Marhaslida Jamaluddin. Topiknya adalah tentang online list survey research methodology, dan peserta wajibnya adalah adik-adik mahasiswa angkatan 2018 semester 5. Tetapi tidak menutup kemungkinan buat Bapak Ibu sekalian, residen, baik staff, kalau seandainya ingin mengikuti acara tersebut, poster akan segera kami bagikan ke departemen. Demikian, mudah-mudahan manfaat acara pada pagi hari ini. Saya mewakili tim SOS, mohon maaf seandainya ada yang kurang berkenan. Ihdinas siratal mustaqim. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Sekarang foto bersama dulu yuk.
Mari foto bersama.
Residen IPM-nya udah pakai semua belum? Virtual background semua belum? Oke, yang mahasiswa S1 udah pada presensi ya? Kalau udah boleh live.
Ya, harusnya tadi sudah juga kok, Dr. Desi.
Yeah.
Ya, jangan lupa tetap ya presensinya di link yang biasanya ya, dari akademik. Dari kita nanti juga ada presensi sendiri, tapi sudah untuk ini jadi sekali aja untuk yang S1 ya.
Yang residen juga sudah presensi ya?
Kita tunggu sebentar ya, Dr. Erwin. Ini soalnya mahasiswanya banyak.
Sebentar ini. Ya.
Di-kick semua satu-satu. Residen IPM yang angkatan 2020 ini baru ikut ya? Baru kali ini muncul, belum perkenalan, tapi nggak apa-apa deh, ayo ikut aja foto. Belum penerimaan resmi, tapi sudah bergabung di acara ini.
Cece Yohana Kunto Arjo itu 2020 ya?
2020.
Terkick oleh hostnya.
Sayang sekali.
Kita tolong dikembalikan.
Boleh diajak masuk lagi, Ayah. Siapa aja namanya? Saya kok lupa. Rosi ada, Ayah.
Jenny juga ke-remove.
Jenny, ya saya nggak pakai nama IPM depannya, jadi.
Iya dok, yang nggak ada IPM depannya, kami nggak tahu dok.
Iya.
Iya,
Ayah ini gimana sih nggak kasih tahu temennya?
Mohon maaf dok, saya kurang tahu.
Ayo Rosi itu apa namanya di rename. Cepat.
Itu Dokter Bima terbalik itu backgroundnya. Bisa
iya, Bima kenapa kok virtual backgroundnya kebalik? Coba diklik mirror my videonya diklik.
Di video settingnya Dokter Bima.
Atas nama Rosi dan atas nama Rosi Susmiyanti, apakah dari IPM dok?
Dari IPM ya.
Dokter Ere.
Sebentar ya Dokter Erwin.
Nah, baik.
Sudah dok, sudah bersih dok. Monggo.
Masih
Lainnya
ada yang
sudah
mau
bersih.
join lagi. Yang tadi.
Oh iya,
Ini
kita tunggu ya dok.
Dokter Nur Ulfah Iperi ini. Kalau Dokter Anis nggak apa-apa. Dokter Anis kan dari tim SOS.
Sampun
Dokter
dok.
Anis yang mana?
Jaga gawang, Dokter Desi.
Ya, tapi kok nggak muncul wajahnya? Kan mau foto dok.
Nah ini udah bergabung.
Ya, ini Yuhana. Nah, Yuhana sudah join. Oke. Terus ada Yeni. Ya, udah lengkap nih ya. Oke, Rosi bisa dikeluarin videonya dong. Nah, yes, sekarang kita bisa foto.
Oke, sebentar saya tata dulu dok.
Dokter Merkurius mau bantu.
Ya?
Ayi kok backgroundnya nggak keluar, Yi.
Saya tata dulu, saya urutkan.
Dokter Ari mana Dokter Ari?
Dokter Rizka, mana Dokter Rizka?
Ada, Ayi ada tuh backgroundnya nggak keluar belum.
Ode, oke.
Prof Safitri.
Oh iya.
Ya, nggak apa-apa Prof, manggil aja. Di unmute Prof.
Oh, Ayah harus dikumpulkan sama 2019. Ntar.
Ya, digeser.
Ya, sudah, Tar.
Bisa.
Ini bisa. Ya, ini Mbak Ari.
Ya, Ayi kumpulin sama 2020 aja juga, soalnya backgroundnya ngeblank gitu.
Iya, Mbak Ayi. Mundur aja deh, Mbak Ayi.
Iya, Ayi ditaruh di aja, barengan sama angkatan 2020. Iya, Kon. Lulus-lulus
Ulang
kok.
lagi loh, Mbak Ari. Ulang lagi PMTL.
PMTL lagi loh ya. Presentasi lagi habis ini.
Baik, semuanya lihat ke kamera, Dok, Prof, dan juga teman-teman. Oke, 1, 2, 3. Dokter Anis tidak on anunya, kameranya, mau on juga, Dok? Oke, lagi. 1, 2, 3. Oke. Sudah 2 kali.
Oke, matur nuwun. Monggo Prof Safitri, barangkali ada yang mau disampaikan pada Dr. Erwin.
Terima kasih
Departemen.
Dr. Erwin atas partisipasinya dalam acara SOS ini. Kami mohon maaf kalau departemen ini selalu ngerepoti Dr. Erwin.
Aman, Prof.
Kami masih butuh ini pengalaman dari Dr. Erwin, bimbingannya, terutama juga untuk adik-adik residen, untuk staf kami muda, supaya nanti dalam pengelolaan pasien yang terkait dengan HIV lebih mantap dan lebih mengerti. Matur nuwun Dr. Erwin rawuhnya.
Sami-sami, Bro. Iya, Bro.
Teman-teman Dr. Erwin, kita semua juga mengucapkan ini kalau ada lagi kesempatan lagi, mudah-mudahan segera terbuka lagi untuk kita bisa mulai bekerja lagi di Sutomo, terutama di UPP gitu ya Dr. Erwin ya.
Silakan.
Atau barangkali kalau di RSUA di IHAN ya Dok ya.
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 Dr. Budi kalau nggak salah di sana.
Ya, nah ya biasanya memang para residen ini kalau di RSUA di penyakit dalam sama Dokter Cahyo sama Dokter Tribudi ya. Baik Dok, matur nuwun Dokter Erwin, monggo kalau mungkin ada agenda yang lain kami ucapkan terima kasih sebesar-besarnya Dok.
Semuanya. Assalamualaikum.
Waalaikumsalam.
Salam.
Alhamdulillah, ya wis keren, selesai.
Dokter Desi bagus topinya tuh.
Kenapa?
Topinya bagus.
Apanya yang bagus?
Topi.
Matching ya sama backgroundnya.
Bagus juga.
Warna-warni, nano-nano.
Ini Rian mana Rian ini?
Oh iya ya.
Tadi bilangnya ke Indomart, Dok.
Ya elah, nggak ikut foto lah. Kemarin waktu panitia Ukom Merkuri yang nggak ikut foto. Sekarang ini Rian nggak ikut foto ganti.
Iya, kabur.
Kabur Dok ke Indomart.
Nah, baiklah. Ini ada Rere atau ada Mas Ical kah?
Ya, masih.
Hadir, Dok.
Masih.
Hadir ya. Oke,
Ya,
makasih ya atas bantuannya untuk hari ini.
Iya, sama-sama. Selamat ya, lancar, Dok.
Alhamdulillah ya. Maafkan kalau sempat ada ketidakcocokan koordinasi ya karena koordinasinya memang mepet banget ya.
Iya dong. Harusnya
Ya,
ada
wes mudah-mudahan
rapat
nanti
gitu kan.
untuk yang
Iya,
berikutnya kita bisa
siap.
koordinasi dengan
Siap.
lebih baik ya, dengan agak lebih ada
Siap.
waktu gitulah ya.
Saya juga mohon maaf kalau
ya.
ada kurang pasnya untuk memfasilitasi, dan mohon maaf juga kalau ada salah, Dok.
Iya, sama-sama. Saya juga biasa kan kita kerja ini nggak cuma sekali 2 kali, jadi ya sudah tahu lah gimana mailnya Dr. Desi itu kayak apa, sudah tahu lah kamu. Ya wes, makasih ya. Ya, kita semua pamit. Makasih Residen semuanya.
Terima kasih banyak.
Dr. Anis.
Mohon maaf kalau misalnya dari tim SOS ada kurang. Terima kasih banyak.
Terima kasih Dr. Anis.
Ya.
Assalamualaikum.